Well, good morning, everyone, and welcome to PerfWeb 63. Our Vanderbilt Faculty Forum, our Tammy Sparacino Journal Club, and everything else that we're doing. So I want to, let me mute this, this thing here. There you go, because I can hear myself over here talking at the same time. Our sponsor, you like that in lack of plurality? Our sponsor is HET. Where's Ramsha? She's not here yet?
Not here yet.
Has anybody texted her to ask where she is?
I'm on live.
One of our faculty is here. Okay, you're on live. You are on live. Our HET. Go to het.us. If you would like to work with us here in Houston, we have an opening in the southeast portion of the greater Houston metropolitan area. If you have an interest in that area or wanting to live down there, work with the absolute best company ever, Perfusion Contract Organization, contact us and you'll get our, I think it's contact@het.us, but you can do it. You can apply right on our website. Okay. Social media. Make sure that you like, follow, share, subscribe, give us the thumbs up, click the bell icon on Facebook, Twitter, LinkedIn, or whichever it is, YouTube, and here's the most important thing. On YouTube, leave us comments. Does there something to click on there to show them, David? No, not yet. So just leave comments in the comments section of our videos. This is so incredibly important, and if we don't start getting some more of these comments, I guess it knocks us down in the ratings, and we really need your help with this. So make comments, nice comments, appropriate comments, comments that are germane to the topic at hand. I don't need more pills being sold to me, so make sure they're good comments. Our websites, Perfusion Education and perfweb.us. I get asked this question all the time. Why is it so confusing? Okay, it's very simple. It's not confusing at all. Perfweb.us is where, you're sitting over there chuckling. Nobody can see you, though. It's not fair. You're making faces at me and everything. Perfweb.us, you'll see Tammy here in just a second. Perfweb.us is where we have our schedule. It's where you'll find everything that we're doing throughout the rest of the year. Actually, the schedule goes all the way through the end of December 2021. That's what year it is, right? 2021.
It is 2021.
And with that said, perfusioneducation.com is a membership site. It's free, the membership. If you need CEU certificates, you can have your own individual folder. It's pretty sweet. You can pay as you go for the certificates, or you can have an unlimited plan, which gives you all of your CEU requirements for the entirety of your 3-year cycle. So to be clear, all of the content's free. We want to share information. There's never any restriction on that. You can watch anything you want, and we appreciate the membership in our site. You know, technically, you can watch on Facebook, you can watch on YouTube, you can watch on Twitter, you can watch on whatever you want to watch on, even through our internal site. But, you know, the membership isn't required to watch the content, but we do appreciate it. It really does help us. We have email address, contact at perfusioneducation.com. to reach out to us. If you want to leave us a message, you want to send us a question, you want to join and be a participant in our faculty, we can do it remotely. As you know, we have Vanderbilt involved in this. We're trying to develop some additional people. We were supposed to do some work with our friends in Spain. In fact, if you are on our YouTube right now, you see Perfuse Find. And these are some of our great colleagues from Europe in Spain, and you know, I just have not had time. We can talk a little bit more as we bring Tammy in about sort of what the paradigm has been here in Houston for us. It's been just a little bit crazy, and I'm not sure it was getting better. Now I'm not sure it is getting better, but we could talk about that. I'd like to talk quickly about our MediWeb app. Oh yeah, the call-in number. Make sure that when you see that, you can call in, be live on the air. I see Magic right now finally turning the telephone on. That's perfect. It's on, and maybe plug it in on top of it. I can't help myself. Well, to see his haircut? Magic just got back from Poland, and look at his hair. He paid for that, obviously in Polish money.
He looks nice.
Yeah, he looks great. And so my haircut looks better than that. All right. So the MediWeb app. Let me pull that up, and we have, Say that again. Yeah. See. Yeah, I don't know what you're telling me to do, dude.
He wants you to talk about the website, but I see the app on the screen.
Which website? Yeah, so go to this site that you see right there and buy the app from either the Apple Store or the Google Store. So real quickly, there are two different apps. You'll see in the top left corner, I can't highlight it on my phone, but you would see it, the Critical Care Perfusion app, and then you have the IV Medcalc. So we're just going to open it up, and I'm just going to show you some of the stuff that it does. And keep it very simple. You have a perfusion section. Now you have a little advertisement that pops up. You have a perfusion section, ECMO, hemodynamics, clinical calculators, an IV calculator, which I'm going to talk about again, and conversions. And if you go to any of these things, so I'm just going to, for the sake of argument, go to the hemodynamics, and you want to know what the SVR is. You put in the mean arterial pressure, 70. You put the CVP. Let's say you're on pump, and it's 0, essentially, and you're flowing, 4.2. I'm sorry, not 42, but 4.2 liters per minute. Calculate, and there's your SVR, 1,332. And if you look up at the top right corner, you'll see that little I, and that's going to give you all of the information. You'll also notice if I go back that it's green, which means it's within normal range. If it's red, it's outside of normal range. So it's a really neat app. But I wanted to also show you the other app, which is the IV Medcalc, which I think is really pretty cool. This is great for nurses on the floor in the ICU. It doesn't make any difference which it is. But if you are doing, let's say, an IV rate in milliliters per hour, and the volume ordered is 500 mLs, and the time for that to be administered is going to be in, let's just do it, hours. And we'll say 24 hours. Calculate. You need 20.83 milliliters per hour for those 24 hours to get your 500 cc's. But it's more sophisticated too, IV drugs. So you have milliliters per hour of your rate. You can have your weight in kilograms or in pounds or in grams if you're doing pediatrics. The amount in milligrams, nanograms, micrograms, grams, units, and then your volumes in liters or milliliters. And so this is a very useful app. It's actually very comprehensive. I showed the simplistic part of it, but very comprehensive. Okay, let's go ahead. I think I got to the podcasts. Don't forget the podcasts.
Oh, yeah.
So we have podcasts. You can, well, I'm sorry. I'm following this is David's list. So we go on the podcasts, and you can go to any of your favorite streaming apps, and you can listen to us. There it is, Spotify and all the other ones that exist. You can just go on there and listen to us while you're in the car, and hopefully learn something. So there you go. We got all of that out of the way. Now, here's Tammy. Thank God you're here. So good morning. And happy anniversary.
Yeah, thanks.
And happy birthday to your son.
Yeah.
Tammy's 7th year anniversary to her husband, Michael, who's an outstanding guy, really tolerates. She has a horrible schedule, and he puts up with it and does. I really appreciate Michael a lot. So I do need to talk to you about the Vandy Faculty Forum this morning. So the participants in that this morning have had a really rough time Matt was going to just basically just gut through it, but he has pneumonia on top of everything else that's going on. So he was going to still do the lecture, and I said, no, Matt, I think this is a really bad idea. I think you need to rest. He has pneumonia for real, and he got it. I guess I can tell you since he told me it was. I don't think it's a secret. He has aspiration pneumonia because he was in the middle of doing an organ transplant or organ transfer from one site to the other, and was just exhausted, drank a monster drink, and ended up, I guess, belching and aspirating, and he got aspiration pneumonia. So Matt is out. But I don't want anybody to be disappointed because I know John Ingram is going to be here, even though he's in the middle of a hurricane, or at least now it's a tropical storm.
Yeah.
But he's down there. Man, I'll tell you what, this live TV is rough. This live TV is rough. Let me tell you what, it's really bad when you're getting these calls in the early in the morning of the programs and then the night before as well. So what we're going to do is I have to have a talk on early goal-directed therapy along with Tammy's journal club, and I thought that my talk dovetailed into yours really well. And by the way, good morning.
Good morning.
So you have anything, what do you think? What's going on? Why is it such a mess?
I don't know. I had a pretty good morning. No hurricanes and no pneumonia.
Mm-hmm.
So
that's good.
It is good.
Yes. So
my mic is on. There is a green light. Do I need a new mic? Maybe.
take that one. Take Ramsha since she's not here.
Try 3.
Hazmat. So her name is Ramsha Azmat, which put her first
Which is
on
one
the.
of our new hires.
Yes, we love her. She's great. In fact, yesterday she had a great. You need to turn that so it's more up. You see what I'm saying? Yeah, because that's what some of it is. Yeah. Okay, so go ahead and talk.
How's that? Is that better? Production team?
1, 2, 3.
My mic
It's
is
good?
good. All right.
Good. Okay, so we got that done. But Ramsha should be here. So
She's coming.
She is. Oh,
Yeah.
you texted her.
No.
No.
I'm on the air.
She's just late.
Perhaps.
Okay. All right. So I'm going to go right into so what's going on? Why are we seeing this uptick again in ECMO? What's happening? Or do you have any thoughts? Because these are both COVID patients. One is certainly long-term, been there for 65 days or 66 days on ECMO now.
Yeah, like 10 weeks.
Yeah. And not, her lungs aren't improving.
But
stable.
she's very stable and not getting any worse.
We need to get her transferred to she needs a transplant. I don't think there's any question about it. But what else? What about this other fellow that we got? So how did this happen? Is he vaccinated, unvaccinated? Do we know where he got it from? Do we know anything about it? Because he's fairly young. He's 47 years old.
Yeah, I don't really know his situation or history. I just know that he's pretty young. Got transferred in a couple weeks ago. COVID positive, but he's about 20 days out now. And now he's on ECMO.
Yeah, yeah.
Which we had kind of slowed down with some of that with...
Seemingly.
Yeah, seemingly.
Yeah. I tell you, it's real interesting, too, because I was watching the news last night, as a matter of fact, and they had and it may have been watching it, it might have been on my phone, I can't really remember where I saw this, but they were saying that the average age of death from COVID is 80 years old, 7 years higher than our national average, our life expectancy, what's considered our life expectancy here in the United States. But my experience has been that, and that may be true, but we don't see those patients.
Yeah, we don't typically see
I've seen
those
an awful
patients.
lot of patients who were in their 30s and 40s that have been dying from COVID.
Well, and I wish I would have read this article. It was one that just kind of flashed across when I was going through my news app. And I thought the headline read that our U.S. life expectancy hasn't been this low since World War II.
Really?
Yeah, but
Wow.
I didn't click on the article. I just scrolled right past it, so I can't tell you any more than that.
Yeah,
but
that's kind of interesting, isn't it?
yeah, it is.
Yeah. Well, you know what? I'm concerned because if it gets any lower, I may not be here tomorrow.
Oh gosh.
Gosh. Okay. All right. So let's go straight to my talk. So my talk, actually, I've done this talk once before, and I really like it. I think it's very germane to this topic, and it's always interested me. I've always been somewhat fascinated by this concept of DO2 and early goal-directed therapy, and really this is intended for the critical care unit.
Mm-hmm.
But I think you're going to be very surprised to see how many or how much oxygen delivery, the significance of it in terms of patient survival and the influences that are in it, how we measure it and everything else. I think you're going to, I'm very fascinated by this as a topic and optimizing oxygen delivery both in the operating room but also in the critical care unit. And I'll talk about a little of the challenges that exist in both of those environments because there's definitely challenges in both of those environments. So I need to give a lot of acknowledgement to Lundy Campbell from UCSF, at least at the time this was published, and also Dr. Crite, and also John Ingram, who was going to be joining us later. He too is also very interested in this, and actually he sort of reignited my interest in it when he had that discussion or had these, he added this to part of his repertoire. And actually I have some of his slides in there, but I think I'm going to actually end before I get to it. It has to do with renal, because this talk that I have here sort of morphs into a little bit of renal dysfunction because of all of this. But these guys have all really become, I think, well established, well known as experts in understanding this concept of oxygen delivery, supraphysiologic oxygen delivery, the significant problems that occur when you are unable to deliver sufficient oxygen and what that long-term oxygen debt can do to us. In fact, if you don't mind my getting sidetracked here, and I know I do that an awful lot, but getting off onto a little bit of a different tangent, my theory, which I've discussed with you, I think already, and I've discussed with several people, is that when the second wave of COVID patients that we got, our outcomes were so much worse. And I theorize that the first wave, which did better, were treated much more quickly and optimized because all attention was given to them, and it was all at a critical care level.
Yes.
It was so novel. And so the second wave, I feel, did poorly because their entrance into the hospital was discouraged and delayed. So they struggled at home. They were in a stress environment. They couldn't breathe well.
Discouraged. Often they would come in, be seen, and then told to go home and check back in.
Yes, that too. Yes, that's true. And then they would come into the hospital and be admitted to a COVID unit, a COVID floor, where they would do a variety of things, trying everything they could to not intubate them. And they would do that for a period of time, proning and high flow oxygen and BiPAP and the whole, or CPAP, I guess, it's CPAP, all of that stuff. And then they would finally decompensate, get to the ICU, be intubated, get resuscitated, stay for a few days like that, continually diminishing saturations with increased oxygen ventilatory settings and all these other things that were done, and then put on ECMO. And my theory is that that difference in time resulted in a compounded inflammatory process from the long-term oxygen debt. And I read your article that you're going to be discussing today, and it was very interesting to me to see how comparing outcomes to SVO2 or lactate levels, let's say from SVO2 versus DO2, had that same, I think, it tends to validate this theory that I have. Now, my theory is my theory. It's untested, it's unproven. It doesn't mean I mean, I certainly am not sure I'm right, but it makes sense to me. If that, I don't know how you feel. What are your thoughts on that?
I think you're right. I think with those patients, they were in such a deficit. They had gotten so weak, often had developed other complications while they were struggling, including, rising lactate. That was one of the things, and, renal problems. And by the time the trigger was pulled for these people to be put on ECMO, they had such huge obstacles to overcome, in addition to their just overall respiratory issues, that's why we had such poor outcomes.
Yeah, I think so. I think you're 100% right. And like the lady, which we, can't give any information about her, but I mean, this is a 40-year-old woman who got COVID.
Our most recent.
She's been on ECMO for, as I said, somewhere around 65, 66 days.
She's awake.
Very much. She is truly single organ failure.
And she's communicating and all of those things.
Absolutely.
She gets PT every day.
But during her PT, what concerns me is that her PO2 falls to 42. Her arterial PO2 drops to 42. And that's not with actual exercise. That's just being in a neuro chair and having to basically bear a very small portion of her own weight. I think that's I think that's very telling of her lack of recoverable lungs. I don't see her lungs recovering. I just don't see that as a possibility. I think she needs a transplant, and that's the only option that she has.
I agree. I agree.
So anyway, let's do this. Can I ask a favor? Can we take 30 seconds? Ramsha has arrived, and I would like to get her up here to the panel, so she's up here at the same time, if that's okay with everybody. So would it be okay? Can I just keep going with my slides, and we can get her up here while I'm doing that? Because you really can't see. So I'm going to keep going with my slides, David. Let's go ahead and do that. And we'll bring Ramsha up, and I'll introduce her once we get a little bit further along. So early observations, and this is a lot of the work that was done by Schumacher, and this was in the late 80s. But he and others published multiple observational studies looking at shock survivors. Most of this is going to be septic shock. And findings were survivors achieve higher values of cardiac index, oxygen delivery, oxygen consumption, and lower oxygen extraction levels. And we'll talk a little bit about oxygen extraction rate and oxygen delivery and consumption, because it is a somewhat inverse relationship. Underlying assumption was that maximizing DO2, or oxygen delivery, would increase oxygen consumption and reduce tissue hypoxemia. Does Schumacher make sense? Well, it seems intuitive that improving tissue oxygenation would be beneficial. And that makes sense to me too. If you remember that device, that microvascular scanner,
yes.
I can't remember the name of it now exactly.
The
microvision scan.
Yes.
Microvision scan. And you look at the microcirculation, the
yes.
capillaries.
Look in the tongue, underneath the tongue.
Yes, in that ridge. Patients who had normal tissue, oxygenation flow, physiology, how nice the capillaries look.
Yeah, remember they line up single file.
Yes.
And they're kind of just moving along. And when they have poor circulation, there's a complete stop sometimes of the blood flow.
And going around capillary bridges and sludging, and there's a lot of derangements that you can actually visualize. She's got a mic.
She got one. This one's not working.
So, and then questions about what level of DO2 should be targeted. Perhaps timing of the interventions are important, and patient selection, it says may be important, but I would say tissue selection, patient selection is likely ultimately important.
Agreed.
Right. Does affecting oxygen delivery matter? Well, many varied and conflicting studies that have been done that cover wide varieties of ICU patients, instituted all at various times, and all of the data collected from all of these various studies is really a methodological quagmire. In other words, a lot of data, very difficult to really condense it down and make sense of it. So back to Schumacher, essentially it was two, and this is from Chest in 1988, it was two very difficult studies in one. There were significant methodological issues, critically ill, non-cardiac, high-risk surgical patients, two groups, control and protocol, each with its own hemodynamic goals. The control was a cardiac index of 2.8 to 3.5 with a O2 delivery of 400 to 550 milliliters, with an oxygen consumption of 120 to 140 milliliters. The protocol group was a cardiac index of greater than 4.5, DO2 greater than 600, and consumption greater than 120. So you immediately note that there is significant increase in oxygen delivery between the two groups, and one is considered essentially, well, it's low. The other, in the critical care unit, is considered supranormal. All groups received fluids, inotropes, vasopressors, vasodilators, whatever was needed at the time to achieve the various goals. In the first series, they looked at 252 patients that were randomized, control versus protocol when they started a study period, pre-op and post-op. Analyzed patient mortality by subgroup, early versus late, which means when the intervention started, control versus protocol, and whether their index was normal at baseline versus elevated at baseline. In all groups combined, the control group, 57 out of 168, or 34%, died. In the protocol group, 21 out of 108, or 19%, died, and they found this to be statistically significant. Patients with normal pre-op hemodynamics, again, the control, 28% mortality, the protocol, 10% mortality, and less than 0.05, again, very statistically significant. So let's go through a little bit of background on oxygen delivery, why measure it, does affecting oxygen delivery matter, how to make sense of these, of this, and any recommendations. So background on oxygen delivery. Let's look at terms, formulas, how to measure it. And by the way, I don't mean to be unapologetically, what would it be called?
Promoting my own app?
Yes, my own app. But you could go to Google Play and the App Store and get my, Ramsha, do you have our app? Yeah. Are you sure? I'm going to check. But it's only $2.99. The big app's $2.99. The other one's 99 cents. Come on.
But what's the reference to the app? You can do these things on the app.
Yeah, go to the MediWeb app.
Yeah.
The critical care perfusion app, or you could get the 99-cent medication app, medication formula app. Okay, I don't want to be go too far. How to measure oxygen delivery through the app, how to measure oxygen consumption, how to measure cardiac output and cardiac index. So let's go through those terms. DO2, oxygen delivery, is the amount of oxygen delivered to the body tissue in 1 minute. You have DO2 equals cardiac output times O2 content. That's CaO2, so it's arterial, right? Oxygen consumption is VO2, and it's the rate of oxygen removed from blood for use by tissues. VO2 is measured through calorimetry, and VO2 is described in milliliters per kilogram per minute. It's cardiac output times the CaO2 minus the CVO2, okay? Oxygen extraction is a slope of DO2 and VO2 relationship, and it's often expressed as O2 extraction rate. You'll see that a lot. And it's CaO2 minus CVO2 divided by CaO2, and normal is 25 to 30%. Why does that make sense? Because what is your normal SVO2? 75. Right, which is 25% of your, or 70%, which would be 30%.
Right.
But it's very interesting to me how, and what you're going to find through this is that compared to measuring DO2 versus only using that as an inference, using your SVO2 is different.
Yeah, I'm going to talk a lot about that.
And that, I'm so really eager to hear about this. And what I also found fascinating through all of this is that, you know, and I think we know this already, but it's still interesting to point out again that where you actually measure your SVO2 from really matters. And jugular bulb is going to be one number, and the right atrium is going to be a different number, and the IVC is going to be a different number, and your pulmonary artery is going to be a different number. There's a lot of variability depending on where you measure it. And when you're on VV ECMO, it becomes even more challenging to really know what the SVO2 is. But what you can do is know what your DO2 is if you know the cardiac output. You have to know the cardiac output to know the DO2. So VV ECMO compared to VA ECMO, even that's a challenge. But VV ECMO is very challenging to really know all of these various different things. Are you going to talk about that too?
No, I am not.
Well, we could discuss that during the discussion points, I hope. So oxygen delivery is not measured directly. It is a formula. Cardiac output times the arterial oxygen content. We all know it's 1.36, or hemoglobin times 1.36 times the saturation plus 0.0031 times the PaO2. Now, for those of you who may be studying for your boards, Ramsha, these are formulas you must know. I know you already know them, but these are formulas you must know. And they're critical formulas. They're the ones that are most important to us, because that formula tells you an awful lot. Knowing what your arterial oxygen content is critically important to what it is we do and how we can affect that, right? Normal values are 1,000 milliliters per minute or 500 milliliters per minute per meter squared. When we do a pump case, and I'm going to deviate from this now for just 1 second if I can, the challenges of using DO2 during a normal cardiopulmonary bypass run is that we are there for two fundamental reasons. The first
They
is
oppose each other.
They do, frequently.
Yes.
One is to keep the patient's physiology within limits normal enough to do no harm. We're not there to heal them. We're not there to fix them. That's the surgery that's being done. But if we try to optimize or do supranormal perfusion, the heart doesn't drain very well. The bronchial circulation is increased. There's all this non-coronary return to the heart, and they can't see to do the operation.
So we either do what we need to do to the patient, or we make the surgeon have a difficult time doing what he needs to do to the patient.
Right. Yes, and they are definitely opposed to each other. So we have to, the art of perfusion is finding the balance between this will not harm this patient, but allows the surgeon to do the operation optimally,
right,
providing they're a good surgeon. Sometimes it doesn't make any difference how perfect it is, but some of the ones that are really good, they're really good. But with that said, you want them to have the best environment for them to see what they're doing, so that their sutures are placed exactly where they want them to be for the best long-term outcome. But we can't have them do a perfect operation and have a patient that doesn't survive because we provided them inadequate perfusion. But we also can't make it so that we're trying to give them a perfect physiologic condition so that the surgeon's outcomes long-term aren't nearly as good. That balance to optimize both of those is why we get paid, and as well as we get paid. That's what we do. Does that make sense? Okay. So the DO2, VO2, or delivery consumption relationship, and go ahead and just, we'll just look at this real quick. Down here, you see the oxygen delivery. Over here, you see oxygen consumption. And if you look here, as oxygen delivery decreases, the slope of your extraction starts to go up, and you reach a supply-dependent zone, which is this cutoff right here. And when you are delivering less than this, you are starting to decrease oxygen consumption, and your lactate levels are going to start going up. So at some point, going the opposite direction, you reach a supply-dependent zone. And no matter how much more oxygen you deliver, it won't matter, because this is where your cutoff point is. So this is what we try to, this is our sweet spot. We want to be just to the right of where this curve starts to fall down. That's what we do. This is yet another example of the same thing. The red is lactates, and the blue is your oxygen consumption. And you can see here, as the, we'll look at the blue, oxygen consumption, and then as the oxygen consumption falls, the red is the lactate, and you see your lactate levels start to rise. So this point right here is called your critical DO2. That's where you do not want to be less than that. Now, can you be less than that for a short period of time? Of course. There are patients who have all kinds of things that happen to them. Is it the short-term 3, 4, 5-minute period of low cardiac output enough to make sure the brain is being perfused, but really your peripheral tissues are really not getting enough? They're getting some, just not enough. Does that really matter in outcomes, or is this really more of a long-term problem, complications associated with this environment, decreasing delivery, rising lactates, all of that kind of thing, take really more like hours versus just minutes while you're on bypass? For example, if you're 28 degrees and they're really struggling and they really can't see and they really need some help, and your calculated cardiac index is 2.4, 2.2, or let's say your flow is calculated at 4, and I cut that in half at 28 degrees, nothing's going to happen to the brain. The brain's going to tolerate it. As long as I'm flowing something, the brain's going to extract whatever oxygen it's going to take the blood that it's going to need. The other tissues will be certainly hypoxic. There's going to be a hypoxic environment for them. But you're at 28 degrees. They'll tolerate it. And then you go back on your full flow and you start to wash all of that out. Will your lactates bump or not? I'm really not sure. We don't measure it routinely, but I'm going to be interested to see what you found in your. Did you explore this aspect of it at all?
I reviewed the commentary article in addition to the article that they were making a commentary on, and then I found an additional article that we're going to discuss more in how to implement it into our practice.
Our practice, yeah. I'm real interested to see that. But, obviously, transient situations of reduced flow during cardiac surgery are very, very common. And our survival in cardiac surgery is, especially for coronary artery bypass surgery, is really good. I mean, for a normal routine cardiac surgery, our survival is very, very high.
Right. I don't think we really need to. I think your point is taken as far as mortality is probably not affected by that, but some of the morbidities that are going to come with it, ventilation time and AKI and just overall length of stay might be affected depending on, what kind of tissues does that patient have, the specific to that patient, and how did those hypoxic events affect them? Did they have perfect kidneys before, or they were already had some insults? I think all of that matters.
Yeah, I think you're right. I think if you already have, if you're living with AKI and you have, let's say 25% renal function remaining, that brief period of time may have a much more profound effect on you than somebody who is younger that is starting off with completely normal kidneys. Or if they have, microvascular disease, they've had diabetes, and they have all of these perfusion deficits at the microcirculatory level already, I would think that would have a more deleterious effect. Yeah, it's very interesting. I think it's an interesting concept. So then you have, VO2 max, and I put this in here because I think it is so critically important to what we do. DO2 isn't just about flow. Remember, DO2 is a formula of your arterial oxygen content times your cardiac output. So you can correct for decreased flows by having increased content. You can also compensate for it by having decreased consumption vis-a-vis temperature. Temperature is your friend when it comes to certain things. And we're going to talk about that because we just changed that ECMO yesterday, which I think you were very excited to do. And I think we learned a lot together about how we can help ourselves get through circumstances that are tenuous sometimes at best. But I put this in here because I know it doesn't look like him, but that's Lance Armstrong.
You didn't have to call him out. Everybody knew who you were referring to.
Well, we have a young crowd. And that is a unit of blood. You see it there. So to increase VO2 max, or your exercise tolerance, and make yourself able to go faster longer, red cells help. Hemoglobin helps. So you a Lance Armstrong fan?
I am.
Okay, well, okay. He's a cheat, in case you didn't know. So he was. It's like taking Mark McGuire's. He's got an asterisk next to his name for all those home runs he hit. He cheated. Cheating is cheating. All right. And he wasn't even nice to his girlfriend. So how to control DO2 at VO2. increase O2 content, increase hemoglobin. Now, with that said, to increase the hemoglobin, you only have two choices: hemoconcentrate. But if you don't have the volume, you can't do that. So if you need the volume too,
You need to add red blood cells.
you have to add red blood cells. Adding red blood cells has its own risks, and there's benefits, but there's risks. Has its own morbidities associated with transfusions. You can increase your FiO2. Well, we're already doing that on pump. Increase the cardiac index. Decrease regional oxygen consumption by controlling fever or controlling temperature, reducing it, and controlling work of breathing. We see this a lot with our ECMO patients who are tachypnic and just breathing 30 times a minute. They are chewing up some oxygen doing that. So sedating and paralyzing those patients makes an enormous difference in how we can optimize their oxygen delivery by reducing, but you're keeping the delivery the same, but you're significantly reducing the consumption.
So the extraction rate is
Yes,
different.
Correct. You're reducing the extraction rate. Exactly. Exactly. There's various, okay, so I think I'm going to stop here. So you have various different ways of measuring your oxygen delivery. There are and cardiac index and everything else. But there's non-invasive ways through thoracic electrical bioimpedance. I think it's nonsense and doesn't really work. There's the minimally invasive, we call it, or less invasive, which is like the LIDCO or the Edwards, not the Vigileo, but the there's another term for it. The flow track is right there. Yeah. Which uses pulse contour analysis. They're pretty decent, but do we really believe them? I don't know. There's the invasive, which is basically doing a esophageal Doppler monitoring, like a TEE with that. You can measure velocities and all that kind of stuff. Transpulmonary cardiac output, pulmonary artery catheter, like a SWAN, which is probably the most.
That's the most accurate, wouldn't you think?
I think so. Yeah. And then you have SCVO2, so that's superior vena cava via oxygen content monitoring, or SVO, not SVO2, but jugular bulb. We'll say jugular bulb. You're measuring the SVO2 from the upper part of the body's drainage. So I think I'm gonna stop there. And let's open it up to some discussion, or would you like to just jump right into your slides and then do discussion? Let's do that. Let's do your slides, and then we'll just jump right into discussion. So let me first open your slides up, files, and
Journal
you
Club
are,
20.
Yeah, I'm looking for it right there. And we're going to go slideshow and presenter view. And here you go. We're going on to Tammy Sparacino's Journal Club.
The casino's at the end.
Number, which number are we?
Well, this is my 20th.
Sure. Huh?
Yeah, he has an intro.
Oh, okay. Let's go to the Journal Club introduction. Sorry.
Yeah, thanks.
Okay. Well, you're welcome. Okay, and welcome back. There you go. We got the Journal Club, Tammy Sparacino Journal Club. The floor is yours.
Thanks for joining us this morning. Today we are going to be discussing an article. It's actually a commentary on another article, and we'll get into that as well. It was published in the Journal of Thoracic and Cardiovascular Surgery Techniques in June of 2020. Title is Commentary, Taking the Next Step in Cardiopulmonary Bypass Management by Dr. Lodge and by Mr. Siffling, who is a perfusionist. Okay, so central message. Cardiopulmonary bypass technology continues to advance. More sophisticated monitoring strategies could be beneficial in improving the outcomes of patients for whom open heart surgery is necessary. Okay, the reason this paper was published is it was a commentary. So it wants to discuss their thoughts, the author's thoughts, on another article that was published in the same journal. And so here is the problems that were to be solved in the article that they're commenting on. So again, this was published in June 2020, same journal. Associations between oxygen delivery and cardiac index with hyperlactemia during cardiopulmonary bypass by Condello and his colleagues. I'll read you the abstract. Metabolism management plays an essential role during cardiopulmonary bypass. There are different metabolic management devices integrated into heart-lung machines. The most commonly used and accepted metabolic target is index oxygen delivery, or DO2, at 280 milliliters per minute per meter squared, and a cardiac index, or CI, of 2.4 liters per minute per meter squared, which can be managed independently or according to other metabolic parameters. Our objective was to compare lactate production during cardiopulmonary bypass procedures using different metabolic management DO2 in relation to indexed oxygen extraction rate, or OER, and CI in relation to mixed venous oxygen saturations.
That's right, mixed venous, SVO2, right?
Yes.
SCV, then there's SCVO2, SVO2, SCVO2. I know
Yes.
there's a lot of different.
Yeah, a lot of different
and it all has-
terminology there.
Right, it's alphabet soup.
It really
and
is.
knowing what they all mean, you have to know it because it's where you're measuring it.
Right, and it can get very confusing, indeed. Okay, so how is this done? So there are methods. Data on 500 cardiopulmonary bypass procedures were retrospectively collected in a specialized regional tertiary cardiac surgery center in Italy. They looked at the time period September 2012 through November 2019. In Group A, the DO2 with 280 milliliters per minute per meter squared target in relationship to OER, or oxygen extraction rate, of 25% was used.
And this is indexed, right? So it's
Yes.
a DO2I.
Yes,
Gotcha.
indexed,
And
correct.
O2ERI.
Yes,
Got
all
it.
indexed. In Group B, the cardiac index with 2.4 liters per minute per meter squared target in relation to SVO2, 75% was used.
Which would be an extraction rate of 25%.
Right. Right. So they're trying to compare two different methods, but trying to still keep the same parameters, if you will, looking at it from two different sides.
Yeah, and to me, of course, I'd have never thought to even consider that, because one seems to, it should make sense that if you've achieved this, for example, an SVO2 is 75,
You should have your extraction rate of 25% because they go together,
so
right?
you should have more than adequate perfusion, which I have believed that for many years.
Right. Okay, so they're looking at two different ways of making sure that they have adequate perfusion. During CPB, serial arterial blood gas analysis with blood lactate and glucose determinations were obtained. So they're going to track the lactate, they're going to track the glucose. Hyperlactatemia, or HL, was defined as peak arterial blood lactate concentrations of greater than 3 millimoles per liter. The post-operative outcome of the patients with or without HL was compared. Okay, so here's their results. 8 pre- and intraoperative factors were found to be significantly associated with peak blood lactate levels during CPB at univariate analysis. HL, which remember stands for high lactate,
Hyperlactatemia.
right? Greater than 3 millimoles per liter, that's what's considered HL, was detected in 15 or 6% of patients in Group A. Remember, Group A is the one that they're tracking the DO2.
Right.
Okay. And in 42 or 16.8% of patients in Group B. It was
Which
not,
is just SVO2.
which just is cardiac index and SVO2. Now, it wasn't statistically significant. However, they did find some things that you might find kind of intuitive and leads you to want to do additional studies in this field. So, hyperglycemia greater than 160 was found in 23 in Group A, which was 9%, 53 in Group B, which was 21%. Patients with HL during CPB had a significant increase in serum creatinine values, higher rate of prolonged mechanical ventilation time, and intensive care unit stay. A cutoff of DO2 of less than 270 milliliters per minute per meter squared in relationship to O2 ER greater than 35 in Group A, and a cutoff of cardiac index less than 2.4 liters per minute per meter squared in relation to SVO2 of less than 65% in Group B were both found to have a positive predictive value of 80% and 75% of HL, respectively. A cutoff of DO2 greater than 290 in relation to oxygen extraction of 24% in Group A, and a cutoff of cardiac index of greater than 2.4 liters per minute per meter squared in relation to SVO2 greater than 75% in Group B were found to have negative predictive values of 78 and 62% of HL, respectively.
Yeah, it's really interesting. I find that fascinating.
It is. And look what a small amount it is. So, you know, we're just talking about, for DO2, the difference is only from 270 to from 280 rather to less than 270. It's you know, so some of them obviously were 270. That's why they chose that particular number to say less than. And the SVO2 only from 75 to 65%. And although I think we all aim to perfuse and have SVO2s greater than 65, 65 is actually usually the cutoff for the bottom level that is considered acceptable. But here they're saying that you know, that's not really acceptable. You've already passed that point.
Yes, but again, and I don't want to belabor this point, but I do think it's at least worth saying and discussing short-term or long-term. So how long were they at that state during their cardiopulmonary bypass
I think they
period?
actually discussed
Was it transient or was it sustained?
Right. I think they took several data points. So let me see if I can find that. They discussed that. Well, here, we'll come back to that when we get to discussion. Let me just continue on. So here's a nice graphic that just is a summary of what I just said. So if that was a lot of letters and numbers to kind of follow along, you can look here. So they had 500 total procedures over about a 7-year period. Group A was the one where they looked at DO2 and oxygen extraction, and Group B was cardiac index and SVO2. And you can see that lactate was considered hyperlactemia in only 15 patients versus 42 patients of the cardiac index group. Glucose greater than 160, 23 patients versus 53 patients in the other group. And here's their conclusions. A significant reduction in intraoperative lactate correlates with better postoperative outcome in terms of creatinine, mechanical ventilation time, and intensive care stay.
So do we need to improve dramatically how we cannulate patients to make sure we can completely decompress the heart and flow enough?
Well, that's actually something, I'm going to not go too deep into that, but that's actually a very smart consideration that, you know, originally these authors either didn't consider or just went with the data they had, but they did not exclude patients based on different types of cannulation. So you had peripheral cannulation as well as central cannulation, and are those really comparable?
No.
Right.
I can answer that
So
question.
that's a problem with this study. Okay, so the conclusions of...
Unless you're doing minimally invasive mitral valve through the right anterior thoracotomy with hyperkalemia technique, as long as you don't have AI.
Yeah.
Because we found out how devastating that is.
It's not good with AI.
No.
So the conclusions of this study article by Condello, this retrospective observational analysis showed that management of DO2 in relation to OER was 16% more specific in terms of negative predictive value for HL during CPB compared to the use of cardiac index in relation to SpO2. Group A reported a significant reduction in the incidence of intraoperative lactate peak correlated with postoperative reduction of serum creatinine value, mechanical ventilation time, and intensive care unit stay compared to Group B. Okay, so this is the article that the commentary was about. Now let's hear what our commentary authors thought about this article. So when I'm talking about authors' conclusions, I'm talking about the original article, so that would be Dr. Lodge and Mr. Sifring. Okay? So they found some limitations, and we've kind of touched on that a little bit. So some of the limitations of this study include variables for which there was no control, because remember this is retrospective, not prospective, such as the inclusion of both open and closed circuits, the use of central and peripheral cannulation. Importantly, the study was used a consecutive patient series in which means, you know, it took place over a long period of time, just all the patients that were within that 7-year period. So our authors of the commentary thought that the control group represented an earlier period than the study group. This calls into question whether an error effect could have been involved because variables and other than the CPB management strategy could have changed over time and affected these observations. In addition, although not all groups, especially in North America, have access to or currently use continuous DO2 in CPB, its use could have advantages because SpO2 might be less sensitive to changes in various tissue beds. The most common correlation for a lower SpO2 and presumably a higher oxygen extraction rate would be to increase the overall CPB flow. And indeed, in the study by Condello and his colleagues, the for the lowest cardiac index on CPB was 2.6 compared to the 2.4 that was in the Group B, which was the control group. It's significantly different. Because the DO2 and the oxygen extraction incorporate more variables, it could have led the perfusionist to increase the pump flow in response to changes that were not observed simply with the SpO2. For one thing, they're monitoring lactate. If you see lactate going up, you know you don't have good perfusion. Of course, you're going to increase your flow, right?
Yes, yes.
Of course. In addition, the patients in the study group, if an increase in pump flow alone did not improve the oxygen extraction, other variables contributing to the oxygen delivery could have been modified. And we have no way of knowing that.
Now, yes. Let me know. I'll wait until you're.
Yeah,
let
I'm
me know
almost
when
done.
I can. Let me know when I can talk. Yes.
Yeah, almost
I got
there.
some thoughts. I'm going to want you to come back to that slide, though.
Okay. So in conclusion, the commentary authors found the findings from the study make an intuitive sense and corroborate the observation that many investigators in surgery and critical care have reported about oxygen delivery and consumption dynamics in patients. Should these findings be validated in a contemporaneous, prospective, or even randomized studies, it should lead to a justification for more widespread use of more contemporary, sophisticated monitoring, which might in turn lead to improved patient outcomes. Okay, so that's it for the, I have a little bit more regarding monitoring DO2, but if you want to discuss this specifically.
Let's go ahead. We can always come back to it. Why don't you finish your thing?
Okay, so
this is really good, by the way. I'm very impressed. Thank you.
It's very interesting. I find this very interesting. I can't wait to hear John's comments on this because I know he loves this too.
He does, and he's I mean, I'd say he's considered certainly one of the experts in this field.
Absolutely. Okay, so really what it comes down to is how could you implement this in your practice? Well, you have
goal-directed perfusion. I just did goal-directed therapy.
I know. I'm not going to go into detail the way you did.
Did you read any of Shoemaker stuff or Shoemaker, however you want to say
I have
his
in the
name?
past.
Yeah, it's really good stuff.
Well, and then Ranucci, and
Ranucci, yeah.
Yeah, the gift trial. Those are all very interesting.
And then that guy from Detroit, Rivers, Manny Rivers.
Oh, okay.
Yeah, he's another big one. But all of this was critical care related, not necessarily perfusion, cardiac surgery related.
Right. And I'm not really going to get into those aspects of it, but those are really good reading if you're interested in goal-directed perfusion. And they can really give you a broader picture, certainly, than I'm going to do about why this targeted perfusion goals can really, can really affect. Specifically, they discuss a lot of AKI and protecting the kidney. But what I wanted to talk about is, as perfusionists, how can we use this, now that we know that DO2 is probably a much better way to gauge how much we need to be flowing to our patients, how can we implement this into our practice? Sometimes we don't have a lot of control over the devices that we use, right?
True.
So if you don't have, let's say, I think the Levanova, their Connect, yes, thank you. Their Connect, it monitors DO2. There's some different devices out there. I'm not familiar with all of them, but let's say you don't have any devices, but you think, wow, this really makes sense. How am I going to be able to do this? There actually was an article that was published in 2019, and I'm going to reference it here, and I'm just going to touch on it a little bit. It's a very short article. I highly recommend that you read it. It was a techniques article published in the Journal of Extracorporeal Technology, and it was by Sry and his colleagues, and here's out in Massachusetts, and they were in the VA hospital there. Here's what they found. I'm going to just read you this abstract, and then I'm just going to get to the main point of their article. Traditionally, blood flow rates on cardiopulmonary bypass are based primarily on the formula that matches cardiac index to the patient's BSA. However, Ranucci and Associates in the goal-directed perfusion trial, also known as GIFT, has shown that coupling the BSA with delivery of oxygen, or DO2, known as goal-directed perfusion, may be a safer approach to determine appropriate blood flows. The objective of this study was to create a goal-directed perfusion reference tool that would allow perfusionists to quickly determine the lowest acceptable blood flow needed to provide a patient of any BSA with a satisfactory DO2 without the need for any additional dedicated technology. We approached this problem by deriving a formula for flow, liters per minute, based on BSA, oxygen content of the blood, and a minimum DO2 of 280. A quick reference GDP chart was created.
And that's a DO2I, right? A
yes,
DO2
yes.
index.
Indexed, yes, indexed. A quick reference GDP chart was created based on the derived formula requiring only the patient's BSA, hemoglobin level, and then you can determine your safe minimum flow rate. The proposed tool allows any cardiac surgery center to adopt this GDP technique even in the absence of instantaneous DO2 monitoring equipment.
Okay. Very interesting.
Yeah, I think it is. And if you want to see how they derived and they had to make a couple of assumptions, read the article. It's really short, again, very informative. But first off, here's what they called the VA Boston Quick Reference Tool for Goal-Directed Perfusion. And you can see running along the top here you've got your, oh, I don't want to do that. Hold on just a second.
What you trying to accomplish?
I just want the dot, so just use my
Oh,
finger.
just use your finger. Yeah.
Okay.
Push and hold.
There we go. So we've got the hemoglobin levels here. So you see they're starting at 7 and they go all the way up to 11. And then over here we've got our BSA, we've got our tiny person going all the way up to 3. Okay, and you can just match them up and say, oh, I have a hemoglobin of 8 and my BSA is 2. My absolute minimum flow would be 4.9. Okay.
Wow.
All right, now don't wow yet. Here's the wow. Here's a comparison if you were using BSA alone and cardiac index alone compared to goal-directed perfusion. So tell me a BSA that you want to look at, Joe.
2.2.
Okay, so we're going to look at 2.2.
Typical patient for us.
All right, and what's the hemoglobin that you want to say that they have?
Well, what they're going to have versus what, okay, so let's say 7.
Okay, so 2.2 and 7. 6.2 would be...
Yeah, you have push and hold with your finger.
I think so. There we go. 6.2 would be what we're supposed to flow.
Wow.
Versus, let's go over here, 2.2. Hold on. There we go. And if we went with a let's just say we were really flowing good and we went ahead and went with 2.4 cardiac index, you can see that 5.3 would be what we're flowing versus 6.2.
So a full liter.
It's a huge difference.
A liter, full liter of flow. That is a lot. That is a big difference.
Yeah, it's a huge difference, and I think it's worth considering. Again, you know, that's the end of my slides. So, well, we can go ahead and start talking about some things.
No, I think that's very. I think that's very interesting because you know there is an argument. I mean that we, you know, there's enough flow, not enough flow,
and too much flow,
and luxurious flow. Well,
yeah.
We'll call it luxurious as opposed to too much. We'll say luxurious. Now, luxurious becomes too much when you are interfering, again, with the reason you're there, which is the surgical procedure. So then it becomes too much.
Yeah.
So there's enough, not enough, luxurious, and too much. So it's actually 4, I think, categories.
Yeah.
Is that assuming, and going back to that slide you just showed, is that assuming 37 degrees?
No. Hold on. And
What temperature is that assuming? Yeah.
So let me see. Let me get into that. So let me find this real quick.
Yeah, it's that one.
Yeah, but hold on. I got to read where they talk about it. Limitations of this tool, arterial blood. Believe the reasonable. Where did they discuss that? I know I read where they discussed that. Maybe it was. Yeah, I think in this one that actually is assuming normothermic.
Right. So we're assuming normothermia, and I do think that we do more normothermic surgery now versus hypothermic. I mean, we don't cool as much, and if we do, we drift, unless we're anticipating a longer than normal pump run.
Well, and if you're only drifting to, let's say, 34 degrees, and then when it's time to warm, you know, you're still got a fair amount of the surgery left, depending on the speed of your surgeon, that you would be at a normothermic temperature.
Well, the size of your patient, how long do you want to warm for? Do you want to have complete rewarming or incomplete rewarming,
right,
etc. So let me introduce some folks, okay? So and then because I have a lot more questions, I want to add some additional people into this discussion. So immediately to my right is Ramsha Azmat. She is she has a bachelor's degree and is a clinical perfusionist. She is licensed in the state of Texas, but she has not completed her American board certification yet. She actually received her bachelor's in general studies with a minor in biology, with minors in biology, chemistry, and health sciences from Texas Tech University in 2018. Recently graduated with a master's degree in cardiovascular perfusion from Rush University in 2021. Congratulations on that graduation. She received extensive training from Advocate Christ Hospital in Chicago, in Theta Care Regional Medical Center in Appleton, Wisconsin, and Ascension in St. John Hospital in Detroit, Michigan. The training did you know Dr. Rivers? Did you ever meet him?
No.
Did you ever hear of him while you were there?
I did.
You did, yeah. The training she received gave her expert experience in the field of perfusion and grew her love for this field. Ramsha also enjoys outdoor activities such as biking. Got to watch out for the bears, though, because that's a really bad deal. And hiking is, again, watch out for the bears. And a great passion for traveling. She also loves shopping, dancing, and Min loves dancing. So you got somebody that can dance with it. And painting as a hobby. So a little bit of a background on Ramsha, which I'd like to discuss a little bit. And you may have to turn her volume up. She's got a very soft, low voice. So you may want to monitor her on this one, okay? She's low. And but you've got a big heart, okay? Low voice, big heart, okay? But Ramsha called me several years ago wanting to shadow. She had an interest in perfusion. And, man, we were busy. We're always busy. And she was so persistent. And finally, I said, okay, yes, Ramsha, we will find a place for you to go and shadow. She went and shadowed at St. Luke's, I believe it was, with Dr. Matoyer. I think Mike Brown was one of those folks. I can't remember who the other people were that you shadowed with. And Clark.
Mm-hmm.
And did I meet you during that time, or we were supposed to meet and I couldn't?
We never were able.
We
to
never
meet.
met. We
No.
never did connect.
No,
But
we never connected.
anyway, so but you did in fact get into training at Rush. You went to a great program. You were trained fantastically, and then you called back and said, "Okay, I'm graduating. I'm ready to come to work for you now." And dude, there was just a no-brainer. I mean, there was a no-brainer at that point in time. Okay,
Yeah.
so excited about it. So this conversation today about DO2 and extraction rates and everything like that. Yesterday was your first experience at changing out an ECMO circuit on a patient who is 100% ECMO dependent. And I think, do you see a lot of what we talked about yesterday and the considerations that and the maneuvers that we did?
Mm-hmm.
Do you see the relationship between all of that with what we did here?
Yes.
So tell us about that.
So yesterday was my first time changing out an ECMO circuit, and this is my first
Where
time.
you were the changer, you were the boss.
Yes,
I was your assistant.
Yes. So before going in, we did talked about what we were gonna do, and some of the maneuvers that we considered was decreasing her temperature to decrease the metabolic demand, putting her on full vent support so she can, it will give us that time.
So do a little bit of preconditioning.
Yeah. And then some other factors that we thought about was giving her heparin so her Avalon cannulation would not clot.
Because we're running basically very low anticoagulation to no anticoagulation, and certainly concerned about that cannula, the blood sitting in it, coagulating. And then what about, I think we used something else to help not only with her comfort, but it would also reduce metabolic demand. What did we do?
We sedated her.
Used some additional sedation, right? And then the 3 keys to success for that whole procedure are what? I don't think I taught you this yesterday.
No, you did not.
First is preparation.
Mm-hmm.
Second is more preparation. Third
More preparation.
is more preparation.
Well,
Be prepared.
Yes. I think you could even expand on that a little bit and say, part of the preparation is making a plan. I think that's one of the most important parts of really anything that we do, but especially in an ECMO circuit change out, is talking about, okay, what are we going to do that's going to help us, which you guys did. You were thinking, instead of having her start in her normal state, which is, although stable for her, would quickly lead to a deficit, let's go ahead and give her luxurious oxygen supply, right? Because she's down off the vent or very minimal vent settings. And then that way she has a little bit more oxygen to extract from while she's going to be, you know, without ECMO flow. Second thing I think too, which is really important, is talking about it, right? You both talked about your roles. You talked about who was going to do what. And I think that that's so important when you're under a time crunch. And of course, changing an ECMO circuit on someone who has very minimal lung capacity for contributing to their oxygen levels, it's key. You want to do it as quickly as possible. And so, you know, planning and then preparing, I guess, and then planning and then talking about it. Those would be my three things for success, just kind of expanding a little bit on what you said.
Absolutely. I agree with you 100%. I'm curious to ask if I can, because, you know, you actually give me a lot of energy because you're me 40 some odd years ago. Now, a lot better looking version of what I was even 40 something years ago, but, you know, regardless, all right, that enthusiasm that you have, that youthful exuberance, which can be, for some older people, annoying, you know, because it's like, oh, okay, I've been here, done that, I don't really, you know, you do find apathy. I'm sure you saw it in your training with some people who just didn't care. They were doing a job. Yeah. But you have a real passion, and that helps me continue to have the enthusiasm that I have. And so I really find it enjoyable, okay? But I want to know from you how you felt. And I remember it very, very well. You had the clamps, you had the scissors, and you had just put the clamp, the tubing in the clamp, but you hadn't yet squeezed it shut. And I looked at you, and I said, "Are you ready?" Because once you do this,
you're committed. You're
committed. There's no going back. How did that feel to know that you now have to do this?
So when I first told you that I want to do this, I was very calm. I was very calm, and pumping all these cases in the past with difficult surgeons and difficult procedures.
We don't have difficult surgeons here.
Yeah, that's so true. Thank God. I was always calm. So I was like, you know, I got this. I'm going to be very calm. I can do it. I was very excited. Did everything in the morning. When you came, I talked to you. I was very calm. We prepped. I was calm. But when... Oh, sorry. Yeah. But when you were like, "Are you ready?" I was like, "This is the time." When I made my first, like when I clamped the venous line first, I started to my heart rate boosted. I was so nervous, but I was like, I can't stop.
You're right. You're right.
You passed go.
You can't stop.
You can't stop. So I was like, I got to do this. And I remember my hands were just shaking, and I knew this patient's life is in my hands. So I was just like, I gotta continue on. So I really don't know how I was able to do it, make those connections, but I was like, I gotta be calm. That's all I had to say. I was like, this patient has to survive.
Well, you did it. You did actually the mechanical part of everything that you did. Was exquisite. I mean, actually, I could tell, I could sense a little bit of those nerves, but you controlled it really well.
Yeah.
What I found interesting, I think I told you this, was, our tubing clamps have 3 clicks. 1, 2, 3. Some of them have 4, but most of them just have 3 clicks. And, you only need 1 click. But when she clamped it, and this was each one of them, she clamped it to the 10th click.
It was not popping off.
No. Well, I was worried that it was never coming off again. Okay, a little bit concerned, because the harder, the more clicks, the harder it is to open it back, and you do have to open it to get the flow back going. All right. So I thought that was very interesting. I was just going to drag John into this. He sits down, then he leaves.
And then
He
he's
sits
gone.
down, then he's gone. He sits down, and he's gone. Here he
There's
is,
John.
Hurricane John. Can you bring Hurricane John into this? Hurricane John. John, you're in Key West, aren't you?
Can you hear me okay?
Yes. The MediWeb Studios
We're
in
coming from
Key West.
fabulous Key West, Florida. First inaugural broadcast from Key West, Florida.
Wow.
Good, good. Asked to participate in the conference that they were having in Europe in Spain, and I just in Brazil. I'm sorry. Why did I say Spain?
Because we have friends in Spain too.
Yeah, and we just couldn't do it, John. We were just so busy. Things were just too much going on, and I felt so bad that we ended up. I've never said no to somebody, and I had to this time. It's just we just had another episode of not just acuity going up and ECMO and cases and all of this stuff, but then, you know, even though we hire people, we have for a whole variety of reasons. People are people. We have lives.
Yeah.
And so we had staffing considerations and complications all going on at the same time. It just got crazy over here. What are you seeing in Orlando?
Well, first off, are you safe? What's the weather like?
Well, we had one little tree down. It's a beautiful sunny day. Yesterday was mostly a lot of wind and rain, and you know,
well, how's it sunny? And how's it sunny with wind and rain?
Yesterday. Today.
Yesterday. Oh, okay. Today it's sunny.
It's always the best day right before the hurricane's beautiful, and right after the hurricane is beautiful because the skies are completely cleared out. There's nothing behind them, just open blue skies. So it's great. But no, it was just a tropical storm. For us down here, that's really nothing. It's really nothing when it's a tropical storm. Even if it's a hurricane 1 or 2. When it gets above 2, yeah, you get a little concerned. But a lot of rain, a little bit of wind. Other than that, it was over in about 8 hours.
Okay.
Well, good, good.
I assumed you weathered the storm at work. You're always working, right?
Oh, I was down here. I've had the last couple of days off, so I came down pretty much right as the storm was coming in, and it was actually no problem getting in. So hanging out at the new place.
Good for you.
Wonderful.
Well, good for you. Key West. That'd be great. You want to start a heart surgery program down there or an ECMO program?
Yeah, sure. They, because the closest heart program is 3.5 hours away in Miami. The county here is called Monroe County. They air flight you for free to the nearest facility if they don't have the service here. So they've done that for many, many years down here.
Wow, outstanding. That's fantastic. That's actually a pretty decent thing. Who pays for that? I mean,
I think it's a collaboration with the county. If you go into the ER here and you have a severe heart attack and you need immediate intervention, we don't have intervention here of any type. We don't have angioplasty or stent or certainly cardiac surgery. The hospitals here are very small community hospitals, and so you get either ground transport if there's enough time for that, or air flighted to the closest hospital in Miami, and I've always been told there's no charge for that.
wow, that's outstanding. So what did you think about all of this? Tammy's talk, my talk, were you able to watch it before you joined?
No, I actually just sat in. I didn't realize it was going to have to be so early, so a little bit of a miscommunication with David, but I just turned on here in the last 10 minutes.
Oh, okay, good.
I'm glad to meet your guest there, though. I heard bits and pieces of her introduction.
Yeah.
Is she presently trying to go to perfusion school, or is she a graduate?
No, she's a graduate. She has a provisional license. She's working. She's able to manage patients independently. No, we got ourselves we hit a home run on this deal.
Oh, I see that. Yeah, she sounded like she has a couple various degrees behind her besides perfusion now.
Yeah, she's actually intelligent, unlike me, right? So our topic today was DO2, and just to kind of catch you up real quick, because I'm curious about your thoughts, but measuring DO2 as a perfusion metric for adequacy of perfusion versus index and SVO2, and what they found was that you had So basically, goal-directed perfusion using DO2, DO2I, and oxygen extraction rate indexed as well. That having a DO2 of, I think you talked about it once before, above, I think it was 280, 280 or above, and an extraction rate of 25% or less was demonstrated to improve outcomes in terms, especially in AKI. So do you want to elaborate, because I know you know a lot about that.
Yeah.
Do you want to elaborate on that at all?
Yeah, that's a fabulous topic, and I've talked about it several times on your show, and even on some of my, as you know, Joe, I've been doing online master's program here. I'm almost finished, and we actually had that topic come up a few times in our master's course as well, where we had to talk about it. But I really believe it's a paradigm shift that needs to be happening. I think it is happening on a lot of hospitals. It's slow to sweep the country. We need to get away from our calculated flows of body surface area or weight, and just looking at the SpO2 coming down the venous line and assuming you have adequate perfusion. That's been demonstrated by many studies that you really need to be focusing on your DO2I, your delivery of oxygen index, of course, because then you're doing it according to the patient's size, right?
Yeah.
And above 272, some people use 280 as a safety margin for that, but 272 and above has been demonstrated. 272 as a milliliters of oxygen per minute delivered per meter squared, I guess it is, the DO2I. And you have a tremendous decrease in all of your ischemic related injuries. And of course, acute kidney injury is at the top of the list because it seems to be one of the more sensitive ones to any type of lacking of delivery of oxygen. And we really, as a field, I think we're slowly evolving that way, and I'm hoping that the newer generations, when we wake up some years from now, that'll be the way everybody's calculating their perfusion flows.
Yeah, well, and you bring up a very good point. The challenges are in, where we've been keeping our hemoglobins and how we're cannulating. We haven't changed cannulation in forever. And so, the kidney is just so uber sensitive to hypoxia and lack of good, perfusion and good flow. I have a curious question for you, if I can, Ramsha, since you just recently finished your training. What are they teaching you in the field now with your clinical rotation sites? What are you seeing in terms of measurement of perfusion adequacy?
So my first site were in Chicago. They did not look at DO2. They just looked at cardiac index, and it was a standard with every single patient.
Did you continuously measure SpO2?
Yes, they did SpO2 measurements.
Was there a low number that you wouldn't accept?
That I wasn't able to pick up. I was not able to pick up I was pretty much there to observe.
Okay.
Yeah, so I tried picking up as much like perfusion related stuff as possible, their measurements, what they look at. And
so they didn't have, like, for example, we track quality as a quality indicator. SpO2 of less than 65, that goes into a metric for a quality report. So you weren't able to speak with them about that,
No.
what their low measurement
What about other places?
Yeah.
So my second place, they did had a CDI monitor in, and so they did look at their DO2s. And then my third site was where they actually taught me about DO2, and they looked at he was the one who pretty much, that clinical site manager pretty much taught me monitoring DO2 was very critical, because you can just flow at the cardiac index, but are you sure you're providing enough flow, or are you providing way too much flow?
You can give him a shout out. He might be watching.
Oh, okay.
So who was your clinical manager there?
Jeff Torres.
Jeff.
Jeffrey Torres. He was at Detroit.
Good job, Jeff.
Yeah, great job.
Yeah. He was the one who really taught me about DO2s. We had a sheet that every time I would pump a case, I would look at that. It was like fit in their computers. So, and looking at it by like their hemoglobin level, then we will decide what flow we need to, pick up.
Mhm.
And we will also look at their urine output to indicate if we're providing adequacy of perfusion.
Yeah, and is John, is urine output a good indicator of renal perfusion necessarily? See,
No.
I've never
Yeah.
considered it's not. No, I didn't
No.
think so.
I know. So why is there such emphasis on, I mean,
I
wouldn't-
think it's old school. I think
very
it's
old school.
old
Yeah.
habits. Old
well,
habits.
I mean, do you still record your pump urine on your
Well, that's for
perfusion
your
record?
I&O. That's just
Well,
for your I&O, but is it really
nobody's
telling you?
nobody's using that. They're using total. They're using total urine during the operative procedure for the I&O. They're not using our pump urine, but yet I'm still recording it on my record.
Yeah, Joe, you're right. It's very old school, and it's not necessarily anything terribly wrong with it, especially back, in the 60s and 70s and 80s, because we said to ourselves, well, how do we know we're perfusing the kidney well enough? Well, if you're making urine, then it must be good enough, because it's good enough to be making urine. So therefore, we need to make urine on pump, and that's basically how it came about,
Yeah.
because we didn't have delivery of oxygen, we didn't have any way, and I don't think we still do, of actually probing the renal arterial flow, as we talked about, Joe, on this show before, to see, what is our actual flow going down the renal artery. So years ago, we said, well, if we're making urine, then the kidneys are functioning. They must be getting adequate perfusion. That's, been many years ago, and we've since learned that there's many, many things that affect urine output other than adequate perfusion. And you can have adequate perfusion and little urine output, and you can have inadequate perfusion and still have urine output. So.
Yeah, and have sometimes high urine output.
Yeah.
Absolutely.
So-
I wanted to talk.
A great topic, if you want to talk about it a little bit more here today for a few more minutes or at another time, is we should ask ourselves, what is wrong with monitoring SpO2? That would be a very interesting back and forth, I think, because it's not everything wrong with it, but there's many things that would give you a high SpO2 that would give you a false sense of security that would, a lot of people using it, and doesn't necessarily mean you have adequate perfusion because, Joe, we're not a fan of phenylephrine on this show.
Right.
And certainly I'm not. And if vasoconstriction, did I lose you guys? Okay. If you have vasoconstriction and shunting around the capillaries, your SpO2 will be nice and high, but you're not perfusing
Yes.
on the capillary level.
Yes, but you could also be delivering adequate oxygen, but if it's not flowing, so even DO2 in that same argument. So it becomes, what do we measure? How much should we measure? What's realistic to measure? For example, we just talked about the microvision scan earlier in the program. You missed that, which is a device that can be used sublingually at a ridge of capillaries that is very close to the surface. And you can actually see the microcirculation in process.
Do we still have that device?
I do.
It's incredible.
They asked for it back. I have it packaged up, but they never sent anyone to pick it up. And I've sort of lost communication with them. So it was supposed to be sent to somebody in Greece or somewhere in Turkey. I'm not sure
really
which.
neat.
But I still have the device. I almost hate giving it back, but I do have it packaged up. It's ready to go. I don't know it's hard to say what's happened with COVID over in Europe, because they were, of course, I think they were Dutch, right? They were from Amsterdam,
Yeah,
right?
Amsterdam.
So a lot of things like that, but it's very interesting to see this. And so you're right. You can have a great SpO2, but you can also have a DO2 index of 290. But if it's not going through the capillary bed because of perfusion deficit, what difference does that make? So do we measure lactates enough? Some devices will measure it, but of course you're only getting a snapshot, right? Our perfusion runs are an hour to 2 hours. If you have a really long perfusion run, certainly you may have enough time to see it. All of these things, including lactate, creatinine, any metabolite, can be so grossly affected by hemodilution. And then how are you measuring your hemoglobin in order to get your SaO2, to know what your DO2 is, And can you believe that measurement?
Well, and most of the point of care devices that we're going to be using when we're on pump are, you know, they're not very accurate
Correct.
for exact hemoglobin measurements.
Correct.
You know, it's plus or minus 2, I think, is most of the devices.
Yeah.
And, you know, 7 to 9, just going back to that.
Now, if you're using coaximetry, it's much better.
Okay.
That's a gold standard. If
Yes.
you're using electrical impedance, like let's say the Abbott iStat device, okay, that uses electrical impedance to measure the hemoglobin, and it's just horribly inaccurate. You have to tell it whether you're on pump or off pump, diluted or not diluted. The more dilution, the more inaccurate it is. But coaximetry is a gold standard, and so I think the GEM may use the new GEM.
Yeah, the new GEM
uses coaximetry. The Siemens Rapid Point uses coaximetry. The radiometer device
but
uses
the
coaximetry.
EPOC does not, right?
No, the EPOC
that's equivalent to iStat.
Yes, it is equally inaccurate.
But,
I don't like the EPOC.
I mean, but for trending, of course, it's fine. But when you're doing these calculations, because there's already assumptions made, you can't have assumptions in every step.
Right.
Because your end result is not going to be nearly as accurate as you would want it to be for sure.
Correct.
You know?
Agreed. And then, you know, there's all these arguments about, you know, viscosity and hypothermia and what is the optimal hematocrit for that and all of these things. You know, I don't know the answer, but I do think that we don't measure enough of the things we should be measuring, and sometimes measure too much of the things that are probably not either helpful or are reliable. Reliability is a huge factor, I think, in what we do. Can we truly rely on these numbers? So should we be measuring, for example, transcranial Doppler? Should we be looking at middle cerebral artery, the MCA flow, for every procedure that we do to make sure we are actually perfusing the brain? Does cerebral oximetry, is that a good alternative to that, and is it reliable?
Well, there's a lot of variability in that, in just setting it up correctly. I mean, you know,
but there's no variability to TCD. There's no variability. There's either flow or there's not.
Well, but you're also talking about devices that require, that are more invasive, that require...
Well, they're not more invasive, they're just more cumbersome.
Okay.
More difficult to use.
And require more setup. So how much more...
You like the way I do that?
Yeah.
I'm very specific.
Adding, how much more are we going to add to every procedure that we have to do, right?
Right, exactly, yes. That's a very, how much are people going to in the room tolerate? The surgeon wants to get the case started. Anesthesia wants to get the case started.
Well,
all of us want to get the case done.
The hospital wants to get the case done. They need to do the next case.
Yes.
There could be an urgent case coming in, and we're adding all of these things to it. So how much is enough and what is not enough of this monitoring that we need to do?
And let's not kid ourselves. Time is money.
Yeah.
And all of this technology costs money.
It does.
So you're making a procedure that should be 3 hours, 4 hours. That's an enormous amount of money in an operating room. And you want all of these fancy devices, which are going to cost us money to buy and maintain.
And train the individuals to use them.
All of that. And interpret them.
Correct.
To make sense, right.
And have enough cases to be able to be competent at that. Because, you know, now that every hospital practically does heart surgery and everything else, that means you're diluting, in these community hospitals, you're diluting the amount of exposure that clinicians are getting to use certain devices. I mean, you know, used to, you were a heart center and your anesthesiologists that came in there were CV anesthesia, and there was no question that they were getting enough TEE experience, for example, to stay certified. But now things are so dilute. Let's say you're at a place that only does 150 hearts. Well, you can't have one anesthesiologist do all of those hearts. It's just never going to work for scheduling purposes, of course. And so then you're having to dilute it out, and then next thing you know, you only have one certified TEE anesthesiologist, because you know they require so many to maintain their certification. So I think that personally, I think that's a problem too. With where you know every hospital shouldn't get to do everything.
Man, that's an that's a good discussion. So, are you a believer in centralization of care?
Well, I don't think it needs to be only med center. I mean, I'm not saying that.
No, not med center, just centralization.
So I think somewhat to a degree, I think it's a good idea. You get clinicians who, I mean, it's like ECMO center. Think about it like that. John's hospital that he works at is an ECMO center. There are ECMO experts that work there. We work at to a lesser degree, but we have some of our hospitals that we practice in are considered ECMO centers outside of the medical center, right? And they do that well. We have other hospitals.
3 of them within walking distance of each other.
Yes.
And if more makes you better, should all 3 of them have the ability to do that? And if not, which one should?
I don't know.
How does that get decided?
I don't know how it gets decided, but I can tell you that I think all of us could easily agree that the ones that we don't do ECMO at frequently, that aren't an ECMO center, if you will, they do it very infrequently. Even if they provide excellent care for this, you know, solitary patient that they got this year that was ECMO, we're not talking about COVID, let's just say, you know, a normal
aspiration pneumonia.
Yeah, whatever, normal year. They're still not at the level that they should be to care for that patient.
Agreed.
Because they don't care for those patients.
Agreed. That is such a very interesting point. John, you're in an ECMO center.
A real
ECMO center. So I'm going to ask you just 2 questions, okay? One is, do you believe in centralization? And again, when I say centralization, it doesn't mean that only in Miami, where the medical center is, that they're the only ones that do, let's just use ECMO since ECMO is such a big thing for us and all that kind of stuff. But it could be anything. It could be spine surgery. I don't care what it is.
Surgery, whatever.
It doesn't matter. But areas around the country where, let's say Orlando, do you have other places that do ECMO, adult ECMO, in the Orlando area?
We are the only adult ECMO center in Orlando. Now, within about 25 to 40 miles just outside of Orlando, we have a couple community hospitals that are decent, that do some, and a lot of times they'll send them to us if they think it's going to be a problem. Of course, another hour, 2 hours away in the bigger towns on the coast, you have ECMOs. But let me answer it this way. In my opinion, if you're not doing at least 25 ECMOs per year, you probably ought to, there is no rule. You could do 1 a year if you want to. But that would be my line in the sand if I was in charge of something, to say if you can't at least do 25 ECMOs a year, you probably need to be a pack and ship type of place.
Right.
Because that's not even 1 every 2 weeks.
But what do you do when you're happy to pack them and ship them, but there's no place to ship them to?
Because no beds? Is that what you mean?
Yeah. No room at the inn.
That's part of your ECMO plan. That's part of your ECMO plan. When you went out and bought the equipment and hired your people to run the ECMO, you had to have a plan of where are we going to send our way too difficult patients. So you shouldn't be just propping up an ECMO program if you can't figure out what you're going to do to get.
At minimum, have a relationship established with an ECMO center or centers that you are able to contact when you get in those types of situations.
So let me give you an example.
Now, I know sometimes they're full and you have to wait a little bit, but if you already have that relationship established, then you should be at the top of the list.
I agree, but let me throw this out at you, and I'm going to get your opinion too. I'm not sure. Are you chomping at the bit to say something? Because if you are, I'm going to let you go.
No.
Okay. So let's say you're in Alexandria, Louisiana, a place that I know very well. There are 2 major hospitals there. Neither one of those hospitals, provide ECMO at all.
No option.
No option.
Yeah.
You do not have that as an option there. If you drive north from here, from Houston, not too terribly far, you have Lufkin and you have Nacogdoches, or Lufkin, Neck of Nowhere, depending on how you want to say it. None of those hospitals up there have ECMO as an option. You go east, not too terribly far from here, there's a hospital that does heart surgery. Now, these hospitals do heart surgery. They're not just, little mini minute clinics, okay? These are hospitals that do heart surgery. So what happens when you arrive there? There's no place to get you to. You continue to deteriorate, and you don't have that as an option, and now you are too sick to transfer. So does it just literally become the luck of the draw that you showed up at the right place for whatever your problem is, that has the ability to, the experience to do it well, and the interest to do it for the particular problem that you are now having?
Yes, sometimes it's just luck.
It's just luck.
I mean,
and is that right? Is that right? Is it right? Is it wrong? Is it
well,
fair? Is it equitable? We're talking about, this is the world of equity, right?
Right.
So is that really fair?
I mean, I don't think fair is an appropriate word to use, because there is no way to make that fair. You can't have everything everywhere. There aren't enough people to maintain training, or to the ones that maintain training to spread them all out across a country as large as ours. I mean, that's one of the things, is being a country as large as we are. We have a lot of resources and choices. However, when you have geography as large as ours, you can't say that it doesn't matter where you go. We're too far apart. And so some of it's just luck.
Yeah.
Yeah, guys, if you had a dime for every time a patient from travels to Orlando for the vacationing, for the theme parks, and is walking around one of the theme parks, has a heart attack, gets lucky enough to be rushed to one of our hospitals, or our hospital, has to go on ECMO, and we saved the day, whereas they would have come from a small town somewhere where they didn't have the capability. In fact, there's many hospitals not far from us that don't have any capability, so they call us, and if we can't take the patient because we're full, I'm sure we all know what ends up happening to that patient. And that is the luck of the draw. There's a lot of luck of the draw in this, because you just can't be everywhere, all things to all people, and you could be at a very lucky spot, and you could be in a very unlucky spot.
Well, I
I'm
mean,
sorry.
And countries that are smaller, or regions that are smaller than us, have different options. That's why the ECPR works so well in Paris. Small area, right? And that's why they would likely be able to implement something like that in some of the European countries, is because they're so much smaller.
Yes.
We can't even do that in Houston, much less Texas.
Yes.
How would that work?
Agreed. I agree. The other thing I wanted to talk about, and we sort of shifted gears, but I want to talk about lactate and creatinine. But it's going to also include hemoglobin.
Okay.
It is very easy to mask a hyperlactatemia, which you were talking about, the HL that you were talking about. Very easy to mask that, especially when you're on cardiopulmonary bypass. Because if you add 500, 700 a liter, you give Del Nido, it doesn't make any difference what it is. However you want to give the volume. You give volume. That volume that you gave will dilute out whatever your lactate or your creatinine or whatever metabolite you were measuring that isn't contained in that fluid, will dilute it and artificially make it low.
Right.
And that happens all of the time. So timing of when we check these things and can we actually measure lactate continuously. Should we have and be demanding devices that measure these values continuously and be accurate? You know, you look at technological advances in cardiac surgery and in medicine, in critical care medicine, and they're phenomenal. But in perfusion, yeah, we have some nice looking heart-lung machines with some neat computers, and maybe we have some good, continuous EMRs, or our electronic charting devices, things like that. But our ability to actually measure the adequacy of our perfusion, everything we do, as far as I can figure out, is inferred.
Yeah.
Everything, all of our ability to measure is an inference based on some snippet of information that we get a little, it's like having one of those movies, like the old style movies that they would turn the pages, you know, real fast, and that would be whatever that's called. And we just basically, it runs, we stop it right there, we look at it, and then it continues to go while we're looking at it. By the time we got it, right, by the time we get the result, from the time we sent it, all kinds of things have happened in between there. And let's use albumin as an example, and hemoglobin. So let's say you run a hemoglobin and it comes back 8.0, just comes back 8. But you're having volume problems, you know the patient has third space, you know you have those problems, so you give the patient 100 grams of albumin. Okay, so you gave that volume, right? And that 100 grams of albumin, now let's say you gave it and it was 100 cc's. So that 100 cc's probably isn't going to affect that hemoglobin very much, if at all. But every gram of hemoglobin draws back 18 cc's
every gram of
albumin from the interstitium. So now you gave that, let's say you drew your lab here, gave that, you have an 1,800 cc difference in volume now in your intravascular space that was not there before.
Yeah, but
are you going to alter a lot of things?
100's a lot. I mean,
but I just used it as an example because the numbers were easier to add up. I didn't want to do less than that.
Yeah.
So let's say 50 grams. You give 50 grams. It's going to be 900 cc's.
Yeah.
You give 25 grams. That's going to be 450 cc's.
But
450 cc's can make a big difference.
Yeah, but typically, aren't you giving more like 12 grams?
No. No, if I'm going to give albumin, I'm going to give 25 grams or more. Yeah. Yeah. Now, you can do that on pump.
Yeah.
And you can do that in the ICU if you are on CRRT. But if you have a patient who is grossly hypoalbuminemic and you have massive, grossly edematous, and you need to get that organ dysfunction is occurring, and you need to get that fluid off that patient quickly, you have to be very careful with albumin because you give it, and if you have no means of removing the fluid, you'll put them into heart failure. So that's a big problem. Now on pump, it's not as much of a problem because you have an open reservoir and it just fills the reservoir up.
Right.
But there is no, there is no toxic level of albumin. And so I don't give little bits of albumin. If I'm going to give albumin, I'm going to give them albumin. John, what are your thoughts on that?
Well, that brings to a point that how many of us monitor our albumin level and our total protein level on bypass? In other words,
our COP, basically.
Right, your COP. So if your COP is, let's just say, grossly low, right, and you do give albumin and it's still below normal, you may not draw over that 1,500 cc's out of the patient. You still may be, your COP may still be too low. On the other hand, if you had a normal or high albumin level and you gave albumin, you would probably draw back over into intravascularly a lot more fluid. So not knowing, like you said, Joe, we're inferring a lot of things. We can't possibly test everything and get the results back quick enough. would be my guess as far as why we don't monitor COP and albumin and stuff on pump, right? It would probably take 45 minutes to get the result back from the lab, at least.
Right.
Well, no, actually, you can measure it if you know the albumin and the globulin, which you can, and really that's such a low contribution. Really, the albumin is probably good enough. And you use our app, you can go to, let's see, let me find COP. There it is right there. So if you know your globulin, let's just say it's 2, and that's not going to change too much, and you could get that preoperatively or whatever, and your albumin level is 4.2, which is the greatest contributor. Your COP is 25.9. It's right there in the app. So you
John,
can
I
measure
hope you have the app.
COP immediately. So anybody out there that doesn't have this app, I need to sell 1 million copies, and I'm retiring, okay? We have a long way to go, but I'm working on it, okay?
Do we have a ticker?
One app at a time. No, it's too low. It's not yet measuring. If you have 1 million, if the range is 1 million, you can't yet see it on the bottom. Okay.
I want a ticker on the back wall.
We're gonna
An app ticker. Every time someone, it rolls.
It rolls. Yeah.
Hey Joe, that could be one of the winning prizes on Tammy's wheel is you win the app.
Yes.
I need to sell 1 million of them, John. Okay, they're getting T-shirts and ball caps and cups.
While we're talking about T-shirts, John, I want to circle back to something you said because I think this deserves to be on a T-shirt. He said,
2 million copies?
No,
we
are not a fan of phenylephrine on this show.
Yes.
That needs to be a T-shirt.
I agree. Let that guy know.
Yeah.
Okay.
Let that guy know. We need that.
And then we got to have something witty, about the kidney.
But I'm not
like we're team kidney or something like that.
Yeah. Well, I think that's you bring up you bring up yet another really good point is that we really don't, when we talk about perfusion, generally speaking, it's really, you have to be in really bad situation to wipe out the gut, right? I mean, a mesenteric infarct or something like that. But, basically, ischemic bowel is not typically a problem that we have during cardiopulmonary bypass. What are the problems we really do have? Limb ischemia is not really a problem for cardiopulmonary bypass. We want to protect the heart. We have cardioplegia for that, right? The lungs, they have their bronchial flow and bronchial circulation, and they seem to do just fine. Sometimes they're a little wet. We have lung problems later, but it's usually secondary to some other issue, not a lack of good flow through the bronchial circulation. The brain and the kidneys.
I know, we have to...
The two organs that are most negatively impacted by perfusion, and we don't really spend a whole lot of time measuring it.
Right.
Well,
or
like
we
you
don't
said,
even think
Joe,
about the consequences of the things that we're doing for one to the other. We're using that phenylephrine because we need our pressure up because we want good flow to the brain. Forget about the kidney.
Right.
Or we're not doing that because we're protecting the kidney and we're not thinking about alternative methods to also make sure we perfuse the brain.
And it's so funny, we talk about phenylephrine these days. So, in the old days, of course, we had norepi, right, like you do now, but we never wanted to use norepi, never. And there was a saying that we had. Ramsha, I'm going to ask you. So norepinephrine is also known as?
Constrictor.
Yeah, what's its other name?
Vasopressin.
No. Levophed.
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 Are you really going to say that?
Yes, because in the old days, whenever they would pull out the Levophed, it was because we were going to leave them dead. Yeah. Levophed is leave them dead. We used to believe that drug was like, that's it.
When you don't have anything else.
When you have to use this, ball game is over. And they just, nobody, they did horrible with it. But it was for other reasons. Now, Levophed is a go-to.
Yeah, I'd much rather have Levophed.
It's changed tremendously.
Yeah.
Joe, how did Levophed get that reputation? Was it because of the alpha vasoconstriction, that part of it, and it left ischemic ischemic limbs and ischemic tissue. Is that how it got that reputation?
Yeah, we basically treated low cardiac output syndrome to get a blood pressure by basically shutting off the circulation to all of the rest of the body, except for the blood pressure the place we were measuring the blood pressure from.
Well, phenylephrine is worse than that. Phenylephrine is a more stronger alpha than levophed.
But we didn't at the time we just didn't really understand that. So neosynephrine was being used, and the patient wasn't responding sufficiently to it, and we were at whatever max dose of neo we were going to use, and then we go to levophed because we're going to leave them dead.
It's phase 2.
So right. So now we have other much more suitable means of improving cardiac output, mechanical devices, whether it be the balloon pump, whether it be, I mean, back in the day when we put balloon pumps in, balloon pumps were big deals. We had to do cut downs on the femoral, and we had to sew a graft on, and then we had to insert the balloon through that graft, and you had to measure it like this. We didn't have fluoro in the room or something like that. I mean, it was a very challenging
we were
thing.
even doing timing.
Yes, we would have to time it. And, the advanced timing were just the slides.
Yeah.
Putting it on 1 to 2 and measuring your inflation and deflation. But back even before that, we had dials for the milliseconds,
oh my gosh,
that you needed to inflate.
For how long it stayed inflated?
And how long it stayed, right, and when it would deflate. So there were dials, and they were in milliseconds. And, so things
John, did you have
changed
dials?
So much.
That was before your time,
I
too.
came along when we had the slides.
I had the slides.
And let me tell you something. There wasn't much ECMO back then, but we would stay up all night in front of the balloon pump as if it were like an ECMO machine, and sitting there and adjusting the inflation and deflation minute to minute.
Yes.
All night long.
Yeah.
I remember doing overnight shifts with balloon pumps. Can you imagine that now?
Yeah. No. No, but then we have Impellas. You have balloon pumps. Then you have Impella. Certainly we have veno-arterial ECMO. Our cannulation is so much. We have come we've come a long way, but in comparison to where everything else technologically has gone, we have gone nowhere. So, it depends on how you want to look at this.
Well, I think electronic charting or EMR, electronic medical records is a perfect example of, I'm not saying I'm for it, but everyone else has gone to it a long time ago, and here we are with our paper charts. Majority of perfusion, I think, still has paper charts, and even if they have converted to some automatic charting, they're still using paper charts for some things.
Yes. Absolutely. I agree. Well, ECMO is a perfect example of that. But what I'm trying to say is that when you look at the technical advancements of society at large, and you compare the changes in technology over the past 50 years, and you look at the changes in technology in perfusion and cardiac surgery, well, maybe not so much cardiac surgery because they're doing robotic and
they're
stuff,
doing minimally invasive.
Let's just say we'll just stay with perfusion. Comparatively, society and everything else has accelerated to here, but perfusion is still here. It's much better than it was, and if you compare where we are to where we were, it looks huge. But if you compare our advancements to the advancements of everything else, we're lagging way behind.
Yeah, I think the commentary, the article that we reviewed for Journal Club, the author says something similar to that. He says, in his intro, he says, I think back to the early CPB machines, such as the one from his particular institution that was pictured in Life magazine in 1957, and wonder, why haven't we come further?
He must have consulted me on that. Okay? He must have consulted. He must know me. Does he know me? Who is it?
Well, I mean, I don't know if that speaking is the perfusionist, Travis Schiffring, or the doctor, Dr. Lodge. I'm not sure who was first person here.
Yeah, they both called me and I talked to them and consulted on that article. Okay, so
are we ready?
Let's go to.
Is it Knowledge Nuggets time?
It's Knowledge Nuggets time. So we're going to go to the introduction for John Ingram's Knowledge Nuggets. I don't know which number it is. It doesn't make any difference.
John will tell you.
All indemitable. So, huh?
I'll tell
It's
you.
10? Number
wait,
John
real
will
quick.
tell us.
Before we go to the intro, are we doing?
We are going to do the wheel after.
Okay,
We are doing the wheel.
Okay, because Ramsey hasn't seen the wheel.
We're doing the wheel. Trust me.
Okay.
So, intro for John Ingram's Knowledge Nuggets.
And we're back.
Hey, and we're back. John
All right,
Ingram.
I got a real treat for you guys today. So just to give you a heads up, the lecture itself is going to be a little bit longer than we've had some pretty short ones here over the summer. Nice and short and sweet, some short ones. This will be a little bit longer, not much, but then it's going to be a nice treat. The gem of the week, you're going to love it. I'm telling you guys, you're going to love it. Florida Keys version of gem of the week. So let's go ahead with the slides, guys. All right, so yes, Knowledge Nuggets, episode number 10. Today's July 7th, 2021. I'm your host, John Ingram. I have no disclosures on this lecture or any others. So what is our motto here at Knowledge Nuggets? Spend a little time and expand your mind. Hence, we got the word nugget from. So this week's topic, how does protamine really neutralize heparin? We'll look into that. So the format, if you've never watched before, it's a different topic each session. Hopefully we're going to give you something you can take home with you. You can take a snapshot of a couple slides, and if you see this little golden nugget right here come up on the screen right there in the corner, you'll know that's a take-home slide, and you can go to work tomorrow and be a better clinician and say, hey, this is what I've learned, and I can apply this to my case tomorrow, hopefully. It's a 12 to 15 minute hopefully high impactful segment. Then we have a 2 to 3 minute perfusion gem of the week surprise. After that, panel discussion and questions. And if you guys could ever want to email me any questions or comments or certainly suggestions for a future show, please email me at john.ingram@perfweb.us. So what is protamine? We're going to take a deep dive into this, all this drug that we all know so much about, or we think we do, right?
You know, we recently had a protamine shortage.
Yeah, I've heard that. I don't think we've experienced it at our hospital, though. So what is the definition? Protamines are small arginine-rich nuclear proteins that replace histones late in the haploid phase of spermatogenesis and are believed essential for sperm condensation and DNA stabilization. Protamine was primarily isolated from salmon fish sperm, but is now increasingly produced through a recombinant biotechnology process. Protamine is available in a sulfate and chloride formulation and is used primarily to reverse heparin. Now let's look at some history, pretty interesting on the history of this, guys. Back in 1868, Friedrich Miescher investigated the cell nucleus in which he identified a nitrogenous base that was bound to some nuclear material of Rhine salmon sperm heads. He named this substance protamine. Subsequent studies by Cossett and others, as they were studying various histones and protamines later, identified these compounds as actually being proteins. Well, back from the beginning of the 20th century, it was revealed that adding protamine to whole blood prolonged the clotting time by interfering with the conversion of prothrombin to thrombin, and this demonstrated that protamine had an anticoagulant effect. Well, for the first half of the 20th century, protamine's primary use was in insulin preparations to prolong the hypoglycemic action of insulin, such as in NPH insulin that you've all heard of. Protamine is still used in insulin today. NPH, in fact, stands for neutral protamine hagedorn. In 1969, protamine sulfate was approved by the FDA here in the United States. In the 70s, protamine replaced the original heparin reversal agent, which was called a drug called polybrine. That was what was used prior to the invention of protamine, for anybody who didn't know that. And it was used in cardiac surgery, and when studies began to reveal in the 70s that polybrine was causing a significant incidence of renal failure, that's when protamine basically replaced polybrine as the heparin reversal agent in cardiac surgery. So what are its main uses? Well, as you guys know, it's the antidote for heparin or heparin overdose. It's used to reverse heparin during cardiac and other vascular surgeries. It's used to reverse unfractionated heparin in the setting of dialysis, invasive vascular procedures, acute ischemic strokes. Well, there's other uses for it as well. It's used to partially reverse low molecular weight heparins, but the degree of reversal in this application is unclear, and this use has not been approved by the FDA, although people still use it for that. The smaller low molecular weight heparin fragments are more difficult to neutralize. It's also used in protein purification. In gene therapy, it's used to increase transduction rates of viral and non-viral mediated delivery mechanisms. So it does have some significant other uses. So look at the mechanism of action. And Joe, I know you love when we have a golden nugget slide. So this is a bit of information that people can snapshot or screenshot. So the way it works, it's a strong basic protein that binds with the acidic heparin, which is acidic, to produce a stable, inactive salt. The binding of protamine to heparin dissociates the antithrombin heparin complex, results in the recovery of the original antithrombin activity. So the great thing about this is that when heparin activates and turbocharges, so to speak, your antithrombin 3, over 1,000-fold increases its activity as an anticoagulant. When you give protamine, it just simply undoes that bond, and the antithrombin 3 can resume its normal activity. So there's no loss or cost of the antithrombin 3 involved with this. So it works extremely well. But protamine has 2 active sites. One of those active sites neutralizes heparin. However, the other active site exerts an anticoagulant effect. The salt, the combination of the protamine and heparin that forms, is inactive and has no, in and of itself, no anticoagulant properties. Protamine has a rapid onset of action, neutralizes unfractionated heparin within 5 minutes, and protamine's half-life is approximately 5 to 7 minutes. So what about giving this drug? What about the administration? To neutralize heparin, it's between 1 and 1.5 milligrams of protamine to be injected for every 100 units of heparin in the circulation. Treatment for low molecular weight heparin is only about 1 milligram per protamine per 100 units of low molecular weight heparin. Now, studying comparing confusion rates of 5, 15, and 30-minute periods showed decreased hemodynamic and coagulopathic complications are associated with slower infusion rates. That's very important there because you've probably seen this, I'm sure, in your practice, where protamine was given more quickly in some places, much slower in other places. Nobody takes 30 minutes to give it. But in the studies that were done where they slowed it down to 30 minutes, the longer they slowed it down, the less the coagulopathic complications resulted. And the hemodynamic changes that people experienced were all less with a slower infusion rates. So also, continuing with this, the efficacy of protamine reversing the heparin can be assessed by measuring the PTT or performing a TE, a thromboelastogram test. ACT is not a good assessment of protamine dose. ACT does not accurately reflect the concentrations of residual heparin. Real quick, we're going to talk about this in a minute, a couple slides, but if you have an elevated ACT after you gave protamine, by that alone, you do not know if you have not given enough protamine and you still have circulating heparin, or you've given too much protamine, and now you have an anticoagulation effect, and your ACT is high. So ACT alone does not reflect if you have a concentration of residual heparin still circulating. In clinical trials, hemodynamic and arterial saturation changes decreased, those effects decreased with infusion via the ascending aorta versus a central venous line infusion, suggesting that this may be the preferred route of administration, meaning that they actually see improvements and people have less negative effects in their hemodynamic changes when the protamine is given in the aortic route versus a venous line administration. So what about dosing strategies? This is important for perfusionists here because we understand that how much we a lot of times determine and tell the anesthesiologist and then what to give, right? If you have an HMS machine or something. Protamine to heparin dosing ratio strategies vary among institutions and are subject largely to the local conventions at that particular institution. The dosing ratio is either based on the initial heparin dose, or it could be based on the total heparin dose that was given during the case. The initial heparin dose with taking heparin consumption into account during the bypass. That's another strategy, that people give the heparin, but they take into account that the heparin's being consumed, and that's very important. I think you should always do that, actually, but some people do not. So now looking at a couple quick studies here, Despotis and his colleagues back in 1996 published in Anesthesia and Analgesia magazine, they studied a protamine to heparin dosing ratio of 0.8 for the total heparin dose administered, and they used 487 patients. They showed that a larger total protamine dose was independently associated with a higher risk of post-operative bleeding and resulted in higher blood transfusions. Machusuki in 1998 and in a separate study, Meisters in 2015, they looked at protamine to heparin dosing of the ratios at 1.3 and above. And they have both reported prolonged ACTs, abnormal viscoelastic clotting times, and impaired platelet function, impaired platelet aggregation. So now, protamine titration should be based on circulating heparin. This is a take-home slide also. Titration of protamine based on measured post-bypass heparin concentrations may improve the accuracy of heparin neutralization and contribute to preserve patient hemostasis. Protamine titration is usually based on the measured heparin concentration, or some people can use anti-2A or anti-10A concentrations to assess that as well. Those are three ways you could assess your heparin concentration remaining. So here's a graph I want to show you guys. And if you look on the left is your bleeding complications. And if you look at the top, if you have underdosing of protamine, you're largely going to have a higher bleeding complications. But when you give a protamine dose there in the blue that equals your circulating heparin, this is of course going to give you the less bleeding complications. And as you begin to give too much protamine and overdose the protamine, your bleeding complications rise, just like in that graph, because there's anticoagulant actions. So what are the anticoagulant properties of protamine? Well, they're largely attributed to decreasing the platelet function. It interferes with the function of the coagulation factors, and it also stimulates fibrinolysis. So this is what too much protamine will do. And, you know, protamine is doing this anyway, but it's binding up with all of that heparin. When you have excess circulating because you gave too much, now that excess is going to have these three effects, and this is why you have an anticoagulation effect. So now this slide is going to show you that protamine has four things that it's doing. Okay, it's doing four different things. The first thing that it's doing, number one there, it's dissociating the antithrombin 3 heparin complex. That's what we want it to do, and therefore it results in heparin neutralization. That's the good thing. But there's three bad things that are happening. It's activating platelets and reducing thrombin generation, which therefore is going to reduce platelet function. That's number one bad thing it's doing. Number two, it's reducing your thrombin generation. It also reduces factor 5, 7, and 8, and therefore it's inhibiting your coagulation process. The third bad thing that it's doing is it reduces the clot strength and your thrombin generation and shortens your lysis time. So it's enhanced fibrinolysis, basically, right? And so these are the three negatives that Protamine is doing out of the one positive that we're giving it for. So what are the adverse effects of giving Protamine? Well, the risk factors for an anaphylactic response, what we always think about when we think about Protamine, patients who take Protamine-containing insulin, as I mentioned before, people who have allergies to fish or fish proteins, or men who've had a prior vasectomy are all at higher risk for an adverse anaphylactic reaction to Protamine. But the common reactions are hypotension, dyspnea, bradycardia, pulmonary hypertension, and of course, anaphylaxis. The serious anaphylactic reactions occurrence is somewhere between about 0.06 to about 1.5% incidence if you study most of the studies nowadays. That's about the number you'll see. Now there's some little known adverse effects that we hardly ever think about. And one of those is thrombocytopenia. And Joe and Tammy, did you guys know that 30% of all patients have a thrombocytopenia effect that lasts 30 days after surgery?
No.
30% of patients have a 30-day impact of thrombocytopenia due to Protamine administration. Protamine also causes complement activation. Protamine is implemented in the cause of vasoplegia. It also decreases our ATP production, and it has a toxic effect on myocardial cells because it induces a level of myocardial injury. Mitochondrial injury, I'm sorry. So here's my conclusion with all this, guys. It's my personal statement here. It's my wish that perfusionists would stop all suctions that drain into the bypass circuit immediately prior to the Protamine administration. And I'd like to discuss that with you guys here afterwards about the techniques that you see out there. But you really, if you study the studies, you should not allow any Protamine into your circuit at all. You can always have problems just waiting to happen. And this will, avoid Protamine being introduced into the bypass circuit. As well as we need to inform the cardiac surgeon and all the OR staff in the room to be vigilant for the be on the watch for adverse reactions. And I also wish that the proper dosing and people would give a slow speed of infusion and appropriately follow those recommendations. So now also, we should have appropriate resources must be available to treat patients who experience these adverse effects. The appropriate laboratory tests should be followed during its administration. Clinicians need to seek feedback from other team members so that the interprofessional team actually functions as a team and not with everyone siloed into their own discipline. And I know, Joe, you have a soft spot for that whole mindset when it comes to things like that in our field. These approaches will lead to proper Protamine use and, I believe, better patient outcomes. So here we go. I think we're coming up with the gem of the week. And as you guys know, if you've never watched before, if you have, the gem of the week can be absolutely anything. It could be a trivia question. It could be a tips on how to succeed in an interview or maybe even in a virtual interview. It could be a hot job topic that's out there, a hot job offer that's out there. And I know, Joe, you've been successful in hiring some great people. It could be anything that we are going on in the perfusion news, in the world of product recalls and some other interesting things. We could talk about something in Perfusion Week, something interesting that's happened there. We could take a famous quote, which we did one week, and expand upon the meaning of some profound quote. Or it could be just some exciting new perfusion meeting that's coming up, like Joe has his New Orleans conference. So this week's episode, Gem of the Week, is the case of the laid-back Florida Keys crocodile. The case of the laid-back Florida Keys crocodile. In August 11th, 2018, and the Miami Herald newspaper reported that there was a surreal scene that was snapped by local Keys resident Victor Perez, who couldn't believe what he was seeing in the canal behind his house. He quotes, "I'm on my balcony, and all of a sudden, I see this pool noodle, and there's a crocodile swimming on top of it," Perez told the Miami Herald newspaper. And there you have the Key West crocodile who has somehow got himself a swimming pool noodle. And that is an actual picture. That's not photoshopped or anything. This really happened. Swimming down the canal, right perfectly centered on a swimming pool noodle. So Perez was a big hit on social media with his post. The crocodile looked like any typical Florida tourist, he said. Well, it remains unclear what pool is now missing one of its toys, but crocodiles are known to be clever, wily creatures that have been at the center of all kinds of unusual incidences, especially when they encounter human development. So there you go, guys. I think we're concluding this week's episode. If anybody has any comments, questions, suggestions for a future topic for an upcoming show, please email me at john.ingram@perfweb.us. And thank you so much. Panel discussion this week, Protamine, and also the case of the laid-back Florida Keys crocodile. Thank you guys for listening.
Great.
Excellent.
That was
very
great.
good. Oh, you got to turn your volume down. Or what do we have to do? Or do we have to turn?
What's wrong?
We're getting feedback. Hold on.
Oh, okay.
Can you hear it? I can hear myself back from his. There you
I'll
go.
turn my volume down.
Wait, I think that fixed it. Yeah, we got it. We got it
Okay.
fixed. Okay. Yeah, that's good. And we
Yeah.
need to still be able to hear you, though. Can you hear us?
I hear you guys good. We're good.
Good. Okay. So, a couple of questions, and I need you to go back on some slides. So, could you bring John's slides back up? Because we're going to need them. So, go back one. Go back another. Go back another. Yeah. So, I just need to confirm, is this a crocodile or is this an alligator? I didn't know.
Well, that's a very good question because I had originally wrote this up as a Florida alligator, which are much more common than crocodiles. But I don't know if you can see it, but if you look to the very, where his nose is.
His
To the
nose
right.
is long.
It's very thin and long, so
Yeah.
he is a crocodile,
Crocodile,
yes.
yeah.
This
Which
is a croc.
Yeah, so right
How do you
about
not
when
know how to recognize a crocodile and an alligator?
Well, I wasn't sure. It could be that was his tail. I can't really tell.
He's swimming that direction.
Well,
he's
yeah, that's
swimming,
true.
towards
Maybe
the
he
right
was
of
in
the screen,
reverse.
right?
Maybe he was in reverse. Okay, so can you go back a few more, like another slide? Okay, now we have that settled. Another slide. Just keep going back to his conclusion. Go ahead, back.
Oh, I think I know which one.
Mhm.
Yeah, we got to get through the gym. It's back in
Yeah.
the presentation.
Slide.
First conclusion
Mhm.
slide, that one,
There you
right?
go.
Is that it?
No, one more. Right there. Perfect. Okay, so my question is these little known adverse effects, thrombocytopenia, complement, vasoplegia, decreased ATP, and toxic effect, is this if you give protamine on its own, you give too much of it, but if you give the exact, let's just hypothetically say the exact right amount, contemporaneous or secondary to the amount of actual circulating heparin you have, and there is no leftover, do you still have these little known adverse effects that could happen?
Very, very much decreased. They would be very much decreased, but you still could have and do have some slight amount of this because remember, by its nature, protamine is automatically doing 4 things on that one slide that I showed you. It goes into the system and it's doing what we give it for. It's causing the unbinding of heparin to antithrombin 3 and then binding with the heparin to form a neutral salt. But while it's doing that, and in the process of doing that, it's also hitting these 3 negative things of causing.
Well, go to that slide. Go back again.
So,
Remember, it's
Hold on a second. Let's just get that slide
one good
up.
slide. I mean,
Keep
one
going.
good effect to 3 bad effects.
Yeah.
One is
Go back. Just
it's
go
the
another-
it's the
just-
graphic that
can you
has
just
the
go-
where he circled all the different things. Yes.
There you go. Yeah. So go ahead, John. That's good. That'll be good visual representation for the audience.
You see there I put number in green is the number 1, which means that's good, that's go. That's what we're hoping to do. But the other 3 that it's doing simultaneously are things we don't think about, but it's having these effects. Now, most of the time, we probably don't notice this too much, but certainly this is another big reason to not overdose your patients at all with protamine, because now it doesn't have anything other to do than these negative things, because it's already bound up all the heparin, right? So then it's left to swim around the circulation doing these other negative things. So this is why, I don't know if you've ever seen, I'm sure you have, protamine anticoagulation due to protamine. I've seen it many
I
times.
have, yes, I have seen it, absolutely.
But
And it's brutal. It's brutal because you're very little you
That's
can do
good.
about
You
it.
can
There's
take it
nothing
down.
you can do to you have to wait it out, and you have to give tons of blood products. And why are you having to give these blood products? Well, because the platelets aren't functioning, you have to give platelets. FFP because you've disrupted the coagulation factors, and now you have fibrinolysis, so you may have to give cryo. So if you really give an overdose of protamine, you're going to see bleeding. You're going to remember that case for a long time, I can tell you that.
you know what
Absolutely.
I find interesting is, John, I'm sure you've heard this before, where, anesthesia, let's say, is calculating the protamine dose, and the surgeon says, how much protamine are you going to give? And they say whatever they say. And he says,
400.
yeah. And he says, I'll only give 300. I don't want to clot off my grafts. Have you heard that?
Yes. That doesn't make any sense.
It makes zero sense. But have you heard that before, John?
Well, because protamine is not a procoagulant.
Right.
By
Right.
any stretch of the imagination.
Right.
If it were, then I guess that statement would make sense. But I can tell you, in my first 5 years of practice, I was at an institution that was very unusual. We had a laboratory, a satellite lab inside the OR. Back in those days, I think you guys have seen this, where you took so long to send it to the main lab that a lot of busy
Yes.
ORs, cardiac ORs, would have a satellite lab right there in the OR. So it was literally down the hall. You get your results, they come back, they hand it to you, and the lab person would come in and out and all that stuff. So we had that, and it was a pretty political thing where the person running that lab had really power over their domain. They really had intimidated just about everybody, the surgeons, anesthesiologists, to stay out. I know what I'm doing, and was very unaccepted to comments or criticism. So people just left her alone. Let's just put it that way. So we would have bleeding problems all the time on a regular cases, tremendous bleeding problems. And I sat there for the longest time, years this went on, scratching my head. I said, this doesn't make any sense. And finally, I got to know her well enough to where I went in and talked with her, and I just asked her, because what we would do is she would come in and tell us the protamine dose.
Oh.
She would tell us what the protamine dose was. And eventually, I started asking questions, and it turns out that the protamine dose was way too high. And what was going on was we had, our initial heparin dose, whatever it was, 35,000 or something, and another, 10,000 or so in the pump. And what she would do is use that amount and never account for any metabolism of the heparin. And we usually had, pretty long bypass runs. Our surgeons weren't very fast. And use that entire amount and multiply that times 1.5
Yeah.
to
Yeah.
get the protamine dose.
Yes.
Yeah.
This was almost double or triple, probably, the
Yes.
protamine dose, and we would have bleeding, and nobody could understand what it was. It was amazing that nobody asked questions, but eventually, the years I was there, I finally started asking questions, and I finally realized that this was because we had lost all control over monitoring what the protamine dose should be. We just took her word for it that she somehow knew, and really it was just a blind calculation. There was no heparin concentration level detecting or HMS or any of that back then.
Well,
you know,
she was doing the same thing those surgeons were doing.
Right.
Just assuming that, in her case, she wanted to give extra to make sure you didn't bleed.
Right.
Where the surgeon that, I've heard that in the past, wanted to not give too much because they didn't want their grafts clotted off,
Right.
but they didn't really understand what the nature of protamine
Right.
itself.
Unless they thought that it was going to normalizing the ACT too early or normalizing the coagulation. So the surgeon may have been thinking, I don't want the patient's coagulation to be completely normal yet. until my grafts have a chance to mature or something. But none of that makes any sense. Who knows what
Well,
some
and the
of these
heparin's
guys
going to wear
think.
off
Right.
anyway.
Right, but I think that goes back full circle to what I was saying earlier, that as far as we've come, we still do things so bloody rudimentarily as opposed and unsophisticated.
Well, don't you think part of that is because this is a new science still? You know, this
Is it? Is it?
I mean, compared
it
to a lot of other things, it is.
Almost 60 years.
Do we have HepCon? We do not have HepCon at any of our
You got to
facilities.
speak up. You got a microphone. Here, when I hear that big booming perfusion voice.
That surgeon, I know what I'm talking about voice. Right?
Yes, exactly.
Yeah.
Yes.
But no, we don't have HepCon at any of our facilities. In fact, it's been a long time since I've been in a facility that used
Well, I don't
HepCon.
think it's a very good device. I don't. I think it was.
Well, this is before Siemens, so it was the only device that did that,
But
right?
even Siemens, I think TEG is really the best, or TEG, or what's that? Rotem, I guess. Is
Rotem.
the competitor to it. But I think that's probably a much more, a much more sophisticated.
Absolutely.
HepCon worked at the time.
Yeah.
But my way of thinking is, if the heparin dose, initial heparin dose was 30,000, and I've given 10, that's 40,000, and I know there's some blood left over in the pump when it's all said and done. Some of it went to the cell saver. You got a 90-minute half-life on the heparin. What was the heparin effect? I mean, there's so many variables involved, but if the calculated protamine dose, let's say at 1.3, or you just did 1-to-1,
Well, just one.
450 milligrams of protamine. I would say, because metabolism is going to continue to take effect, I would maybe do 2/3 of that if I were calculating the protamine dose when I was at places where they would ask us.
Mm-hmm.
There were even places I used to work where we would mix up the protamine in a bag because no one else in the room was allowed to have it because they had an incident at one point in time.
Yeah, everybody's heard about those
And
incidents.
The incidents, right, the incident, right.
Yeah.
Where, do you know what the incident is? The incident is somebody giving protamine while you were still on pump.
Yeah.
That's
And the somebody was anesthesia.
yeah. The outcome.
And-
Everything is anesthesia's fault. That's
No,
another thing you need to
That's
understand.
not true.
It's
but
true.
in
If
my
it
incident,
rains
it
on
was.
your wedding day, it's anesthesia's fault. Just remember
But
that.
it's not anesthesia's fault if you're coming off bypass and you don't notice they haven't started ventilating.
Yeah.
That's true.
That's your fault too.
Yeah. But you notice it in the pulse ox pretty quick.
Yeah.
Mhm.
Yeah. But
And
that
it-
happened to me.
Yeah. That'll happen.
Yeah.
Yeah.
Mm.
Yeah.
Well,
Scary.
there's many an OR where protamine is absolutely banned to being allowed to be in the room until it's asked for.
Well, and John, I'll give you one more. You know, we work at some places where they do what you talked about, where you give protamine in the aortic root to hopefully avoid some of these problems. And
The first pass theory.
yeah, first pass theory. And it's drawn up in a syringe, and you know, what else do we drop in syringes on surgical? Not us, but what else is drawn up in syringes on surgical fields for use in bypass surgery? A lot of times it's cardioplegia, right?
Yeah.
Yeah, I've
I've
seen
seen
that.
it.
I've seen that happen.
Whoa, That's a good one
Yeah, graft
Mhm.
clotted off pretty quick.
because of cardioplegia.
No, because
Oh, they gave protamine instead of cardioplegia. Ah,
yes,
okay.
during
gotcha.
the surgery, right?
Yeah. Yeah. Ooh, that's a bad one.
Yeah.
Yeah, that's a bad one. Yeah, but getting back to that surgeon you were talking about, you come off pump, and you give you decannulate, you get the venous out, you give the protamine, and they see any continued bleeding at all, and the first words out of their mouth.
Give some more protamine.
Yeah, well, let's give a little more protamine. That may be the absolute worst thing to do. And almost always, now, if that patient had gotten like a 900 dose of Plavix before we took him to the operating room, we know there's going to be. When I got those cases, dude, I would just say, get 6 FFP thawed, get 4, jumbo packs of platelets, and get, about 4 or 5 units, 4 or 6 units of packed cells. Just do like almost an MTP, a mass transfusion protocol. Just have it all in here because we're gonna need it. Because
Right.
there's no way to reverse that.
Or do a tag before with platelet mapping, and
Yeah,
you
we
know
didn't have tag.
know exactly.
Just get everything. Well, that's the thing. When you don't have tag, when you don't have these sophisticated tools, you shotgun it. That's what you do. And we did it. I can't tell you how many times I would add all of it to the pump coming off bypass, infuse it through the pump to get it into the patient, and then come off, give the protamine, and pray. Because they would bleed so bad, you couldn't get the products in before you had bled all the products out, and you could never get control of it.
What was that one, that drug that was around for a little while that they were calling Superplavix?
Yeah, I don't remember that one. But yeah, Superplavix, yeah.
John, do you remember what I'm talking about? Maybe about 10 years ago, 15 years ago?
Yeah.
Anyway, it was some amped up version of Plavix, and we had a patient like that. They had been given that, had a cath procedure, went bad, emergent bypass, and no matter how many products we got in them, they couldn't stop bleeding.
Yeah.
They expired. We couldn't.
Yes, that happens. But exactly. So sometimes they're bleeding. It's almost always, unless those circumstances, it's almost always prolinemia.
Yeah.
But let's just give a little more protamine, and we'll just wait here.
Well,
how about just
wait a minute?
Put a stitch in. Put a stitch in. Don't sit there, and you don't want to admit that your suture line wasn't any good. Admit it, take responsibility for it, and put a suture in. But they won't. They'll stand there. It's not what it is. Mm-hmm.
Not our surgeons, though.
Mm-hmm.
Ours are great.
Exactly.
Okay,
well, very good.
Well, great talk, John. Thank you. That was wonderful.
That was.
In the example where I said my first job, which by the way, that hospital is long since closed. So, but anyway, what I think happened here over the years was that they were giving borderline enough, maybe a little too much protamine, and so they were getting away with it. But then all of a sudden they'd have this bleeding problem, and the first thing that the surgeons or somebody criticized this lab tech for was, we need to give more protamine. We're not giving enough protamine. So she upped her little calculation. Yeah. And then it would happen again, and she upped her calculation. So lo and behold, when I come and I get hired, they've been doing this already for 10 or 15 years. Now it's already way over here.
Yeah.
And I think it was
she's not 1.1, she's 1.5 or 1.6 or whatever.
She started off at 1 or 1.3, and now it's 1.5, and then she added more for the pump prime and whatever else. And we're now, way over here, and nobody knows what to do anymore. So they just kind of dealt with it every day. It was really unbelievable how much bleeding we would have. And it was always, looking back, it was always from an overdose of protamine. It had to be.
So, John, I'm going to go. This has been a great show. Did you have any additional comments? No. I'm going to go grab a couple of things right here. So if you would please discuss, because we're going to go to the Tammy Sparacino Journal Club Casino wheel spin.
John says it better than you. Say it, John.
Tammy Sparacino's Journal Club Casino.
See?
There you go. Okay,
so good.
Very good. Okay, finally, somebody on Earth can do one thing better than me. Finally.
God.
Finally.
And Joe, we're going to get you a T-shirt. We're going to get you a T-shirt that says, I thought I was wrong once, but I was mistaken.
Exactly. That's my perfect
Exactly.
I totally agree with that. I totally agree. Okay, we'll go get a couple of things. So would you please talk about your buddy with all of this and sort of give a little preview for everybody while I go get these props, because we're spinning the wheel for our introductory, our guests' inaugural participation in the program, Ramsha. So I'm going to go get a couple of things. So talk about your friend.
Yeah, so, I want to talk about one thing real quick. My friend Alan Klima is the one who came up with all these products that sent to Joe, pretty much doing it complimentary. He is working
Thanks,
on a
buddy.
website at some point, but really just wants to contribute something to the field to have fun and to make some lively shirts and hats and stuff for people. And they're a pretty big hit. Wherever he goes, people ask him for them. And really didn't even endeavor to try to make any money off it. I think he's just having fun with it. But he does a bang-up job,
What's
and
in
he's
your
willing to do
coffee?
custom stuff for people too, by the way.
I'm
He's willing, if
excited,
you have
John.
an idea, yeah, if you have an
I-
idea or you want something, he has a way of just making it up for you somehow. And
I haven't seen any of this yet because remember I haven't been here the last
Oh,
two
you
journal
haven't
clubs.
seen it?
No, so I'm
ton of
excited.
stuff. Sweatshirts, T-shirts, surgical caps, bandana, baseball caps, 4 or 5 different colors and styles even. Yeah.
Yep. Okay. So, and we have our purple cup. Can you see all of these things? Okay. So we have. Here, let me not.
Yeah, you're in the way, I think.
I'm sorry. Here, let me stand on this.
You
side.
might. I think the T-shirts might be too low.
Here,
Yeah.
You got to put them up by your computer, Joe. Hang them up by your computer.
Here, I'll just do it right here. I'll do it over here by Ramshaw.
There we go.
T-shirts.
Yeah, is that great or what?
Yeah.
We have hats.
We give your heart a rest.
That's
Do
good,
you see
yeah.
that?
We have a perf web cup. We have surgical caps and
me
one
see.
that's black
yeah.
over there.
Yep.
You can see it. Okay, good. So now we have the wheel. Okay, so
We need to share
Tammy,
screen, right?
it's already shared, so it should be up.
Let David pull it up for us.
So this is the highlight of our day.
Yeah.
All right.
So this is for Ramsha.
This is for Ramsha. So Tammy is gonna. Well, should she spin it or do you spin it?
Hey.
Who spins it?
Oh, she has to spin it.
So
She has
Tammy, who spins it?
to- Ramsha.
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 Okay.
Okay. So
Ramsha.
Here we go.
all right. So this is for your winnings. So you
Watch
spin.
out because there's some ones you don't want.
Yeah. So let's see
Like-
what you're gonna. So hit spin. No,
Yeah,
spin
just
right
right
there. All right. Here we go. Where's the sound effects? There we go.
Oh, come on, stop there. Oh, she got extra.
You got extra call! Yes! Ramsha on her inaugural day wins extra call. All right, we're going to give you another chance. We're going to let you spin it again, Ramsha. Spin it again.
Twice in a row now.
Oh,
All right.
there we go.
Okay.
You win a ball cap.
All right.
Okay, you get to pick whichever color you want. You've got blue. You have
Camo.
Camo. There's here. Look, there's blue and white. There's I think there's green. There's green. Which would you like? Blue?
She likes
Okay,
the
so
blue.
let's put it on and get a good picture of Ramsha. Let's all get together with Ramsha here. And get John in. There you go. John in there. Now, this makes you now you're a real perfusionist, Ramsha. I want you to go in and do that ECMO. I want you to check on an ECMO patient with that ball cap on. Okay? All right. Good job. All right. So our next program is, does anybody know when it is?
It's the first Wednesday of the month.
No, I think there's one before that.
Oh, what, your next program?
Yeah, hold on. Here it comes. It is on July 22nd, and it's use of polypropylene
Oh.
and polymethylpentene or PMP fibers for ECMO oxygenators.
Yeah, that's the talk you didn't get to give.
Yes, I have not gotten a chance to give that talk yet. So
Okay.
that's going to be Thursday, July 22nd.
That's an afternoon
Starting
program.
at 2:45 p.m. Yep, afternoon. And then our next VUMC faculty forum is Wednesday, August 4th. And that topic is going to be, we're probably going to go and do the one we missed today,
Alpha-stat.
and PH stat. I'll have to get with Matt and talk to him about that. Before I forget, let's please wish Matt well. He's going to be fine. He's not, He isn't going on ECMO anytime soon, but he sounded really.
Poor Matt.
And he was going to do it today. He was still going to do it. But you know what?
If that would be me, you makes me do it.
Yes, I would. Come here, Magic. Come here. Come here, man. Come here.
Be careful.
I would make you do it. Come here.
No, because
Go
I
stand
know
next to
what
Tammy.
you want to say.
You know what I'm going to say?
He's going to
You know
talk
what I'm
about
gonna
your
say?
hair.
Magic, here's our producer, and he just got back. Our technical, no, David, you're the producer, right?
Yeah, sure.
Okay, Magic is what are you? The technical director. That's it, technical director. So I don't know if you can zoom in on Magic or not, but Magic just got back from Poland. He went to Poland to go get his teeth worked on because it was cheaper and he had air miles. But he got his hair cut while he was in Poland.
I borrowed this one.
Much better, much better. So for those of you out there that watch our program and participate, and thank you for the comments, by the way, we appreciate that so very much. I want to thank everybody, and we will see you on the 22nd with our next program. Ramsha, excellent work, very good. Looking forward to you having a long career. If you see me, make sure you take good care of me. Tammy Sparacino, thank you again. It was an excellent journal club. John Ingram, you're always fantastic. Enjoy Key West. Thank you for taking time out of your day and vacation to participate, and all of you for watching our program. We will see you all again soon. Thank you very much. Peace out.
Bye-bye.
Bye, guys.